important that you go beyond your boundaries and try to share. Now, when you submit a manuscript, let's assume you're writing an original article and you submit your manuscript, it would help for you to understand what that process looks like at the back end. A lot of times we get this feedback from authors that, oh, I submitted my manuscript and I don't know what's happening. I don't know where it's lost. So our purpose is to kind of help you through that process, right? So when you submit your manuscript, it goes into a journal editor screening. Now this stage, this one here, this is the one where maximum manuscripts are rejected. So at this stage, an average journal, like not a very super high impact journal like the Lancet, even a basic journal they have a team of editors. They have a team of at least 4 to 5 editors, and each editor receives about 10 to 15 manuscripts per day. So every day they have to review 10 to 15 manuscripts. And when they are reviewing so many manuscripts per day, that's a lot of work for one person. So sometimes there have been instances where they will just read the title and they will reject your manuscript. That is high the rejection rate. That is how high the rejection rate is at that stage. So depending on the journals that you submitted to, 6 to 60% of the manuscripts get rejected at this stage. Our purpose is to support you as much as we can at this point itself, so that you can go past that manuscript screening. If you go past the manuscript screening, that's where the manuscript goes into a peer review. So all high quality journals, all journals that follow a rigorous review process must go through at least minimum 2 peer reviews. The good high impact journals have up to 10 peer reviews, and these peer reviews can be single blind or double blind. So at the peer review stage, you will either get concrete feedback on why the manuscript was rejected or not. If you don't get feedback, then you can actually make an attempt to reach out to the journal editor or to the publisher to try to get feedback on why your manuscript was rejected. Or they would give you feedback with the option to work on it further. They'll give you feedback where you can actually incorporate the comments from the peer reviewers and then resubmit your manuscript. So that would happen over here. Once the peer review stage is done, then it still goes through a final journal editorial board. So sometimes your manuscript may get accepted at a peer review stage, but the journal editorial board can take a decision to not publish for very different reasons. So that could be a strategic decision, it could be a political decision that the journal takes. It's not against you as a researcher, it's against a certain industry issue that they're probably standing up for, and that's why they might, very rarely they might reject it at this stage as well. So for example, when the Ukraine war broke out, a lot of journals stopped publishing research from Russia. That's sort of an example, right? So that's very rare, but it might happen. If the editorial board also accepts your manuscript, at that point you would get a letter stating the date or stating that your article has been accepted, and the letter will include the date and the issue number where your article will get published. So that's the high level process you need to be aware of. Typically, a lot of the good journals try to complete this process in about 6 weeks, but realistically the timeline can extend up to 6 months. So you will always get an email when you email on what the timelines look like, and if the timelines extend beyond what is stated in the email, which very often they will, you should again try to reach out to the editor or the publisher to find out like what happened, and that's where our team can also support, right? So this is the real question of the day, right? Why do papers get rejected at that manuscript screening stage? This is what we're here to discuss. Now I purposely picked up an Indian paper on this subject. There's a lot of research across different domains on why papers get rejected, but I purposely picked this one up, and you'll notice that the top 2 reasons for rejection are these. The number 1 is lack of clarity and originality, and the number 2 reason is out of scope. So we're going to focus on these a little bit. Now this is feedback coming directly from the journal Nature. When we say lack of clarity, what we're trying to say is that it must be very, very clear and apparent on what is the new information that you're bringing to the table. So the idea here is that make your manuscripts as simple and straightforward as possible. We are not looking for high level English, long sentences, no. The idea is that you need to be able to convey to the reader what is the most important information in your manuscript, why is it relevant to the reader, and how did you arrive at it. These three questions should be covered in your manuscript in the simplest manner possible. If you can somehow convey this in the title itself, nothing like it. If not the title, at least title and abstract should convey these three most important pieces of information as simply as possible. Because let's face it, we now live in a world where not only academicians are reading your research, now even a lot of people read research. People have access to a lot of content, and that content can be read and misread in so many different ways. So it's important that you keep your papers simple, clear, concise, and to the point. We need to know very clearly what is the new information, why is it relevant, and how did you arrive at it. So the other big reason that we mentioned, the second reason for rejection is out of scope. So this is what this means. Out of scope does not mean that the research is out of scope. Out of scope means that the research does not align with the journal aim and scope. So for those of you who are experienced authors, you would know that when you identify a journal that you want to publish in, you need to go into the journal guide for authors, or the author's guide, right? The first thing that the author's guide will tell you is the journal aim and scope. The journal's aim is what they are all about. Maybe it's the journal is about sexual health. Maybe the journal is about transformative research. Maybe the journal is about population health. And the scope of that journal. So the scope may be something like, we're going to write for the Indian people. We're going to write for otorhinologists. Or we're going to write for consumers in Russia. So that's your journal aim and scope. And it's a very, very fine balance. So for example, if you have a pediatric neurology paper and you submit it to a neurology journal, that really may or may not align with the journal aim and scope. That's why it's very important for you to first understand the journal aim and scope, and then also spend some time in reading the most recent issues of that journal to understand that within their journal aim and scope, what exactly are they talking about for the last couple of months or couple of years, to really make sure that your manuscript aligns with that. So that is actually the second. There's nothing wrong with your manuscript, but it's a journal's choice that this is not fitting for us. The author needs to explore a different journal which is better aligned. And these are the top two reasons. Apart from those two reasons, then we come to other questions like, is the question clear? Is the study design appropriate? Is the study valid? Is the study research presented correctly or not? So all of this comes later. The first two things that editorial editors look for is, number one, is the research clear, concise, and to the point? That's point number one. Number two, does it align with the journal aim and scope? And let me ask you this. We're all familiar with this? Show me, raise your hands to tell me which of these topics would you read first?
Abstract.
Title abstract? Anybody thinks differently?
Methodology.
Abstract, after that's methodology.
Methodology.
Sorry, it's gone.
If you're familiar with the area, we would also want to see the conclusions.
Results, yeah. Title and then results.
So in reality, the order or the order in which you read a paper, or the time that you give to each section of a paper, actually depends on your day job. It depends on your role. If you are a practicing clinician and you're just looking for evidence to adopt into practice or to guide your practice, chances are that you're looking at title and abstract. Right? You would spend most of your time looking at title and abstract because you're using that information to guide your practice. If you are a researcher, then you would then next look at the conclusions and limitations because you're trying to understand what did you find. You're coming to that question of what is the new information. And then if you're a researcher who's actually working on that topic and wants to create another research project, then you would look at methodology, right? From an editorial standpoint, we start with this actually. So, coming back to the point about your paper being logical, concise, and to the points. one of the things that editors closely look at is the quality of your tables and figures. So sort of like a rule of thumb is that by flipping through the tables and figures in a paper, by figures I mean both images and the charts or graphs if you have any charts and graphs. By flipping through the tables and figures in a paper, if the reader can come to the same conclusions as the author, then by and large your logic is in place, right? So coming back to that original argument that your paper needs to be crisp, concise and logical, one way to do that is by making sure that your tables and figures are to point. And actually this is an area where we get a lot of errors, a lot of reasons for rejection. So I've summarized them here. I'm not going to go through all of these points. You can always read them in your own time because you'll have the slides, but it's important to think about why this is important. So the tables and figures in your paper help you tell your story better. The tables and figures help you tell your story more effectively and by using less words. You should use your tables and figures to be able to tell it in fewer words, right? So the way to do that is by making sure that you use tables and figures in an efficient manner where you can replace the words, right? But at the same time, I think I'm going to skip to the next slide to demonstrate what I'm talking about. Do you see this? I challenge you to try to infer what this means. No, right? So this manuscript has so many numbers and it makes it virtually impossible for the reader to understand 161 is a subgroup of which of the, and then this happens to the screen, which it does in reality as well. It's literally impossible to read this. This is exactly the kind of text which could have been much better represented in this manner. And even this is still not perfect because to us, especially our Indian eye, when we see this table, the first thing we do is we add up the percentages. And the percentages here are not adding up. So if somebody received this, this would be the immediate reason for rejection. And if you go into clinical key, which I think all Apollo people have access to, there are so many papers telling you why it is important to maintain table hygiene when you're writing. So if you search for writing a scientific paper in clinical key, you will get a lot of guidelines, a lot of information, a lot of guidance on these points, and one of those is exactly this, like how messy tables can be if you don't spend time in working through them. So you can make really effective tables by using spacing, by using fonts, by using font size. Of course, it all depends on the author guidelines. The author guidelines will clearly mention what is the font and font size to use, whether your table should have a title, how big your legend can be. Those specifications are there. But despite those specifications, you can be creative in the range of the font size and the spaces that you're putting in to make your table look cleaner. So for example, instead of this, a better representation is this. So here the author has used spacing to clearly show what are the different groups within the sample. And this is nothing but just using design thinking. I understand Apollo's been also talking about design thinking, right? So this is how you can take your knowledge and workshops on design thinking and apply it when you're writing your paper to really think about that. If I'm just writing, if I was the reader and I looked at this table, what is the first thing I would do? The first thing I would do is add the percentages, and I need to make sure that my percentages and my N on top add up. So these little mistakes become very apparent when we start looking at manuscripts, and it's very important we avoid them. I won't go into all these details, but I will point this out. So you see, even in the guide for authors, the portion about tables and figures has its own section. That's how important it is, that they've devoted an entire chapter just to this guide for tables and figures in the guide for authors. And so all of this information is actually available to you either on Clinical Key or some of the other platforms that you're subscribing to from Elsevier. I'm not sharing anything that you don't have access to, so you can just click on these links and go into it for more information. Now Now, apart from tables and figures, a couple of other very important sections that really can make or break your paper are these. The first one is results. The problem with manuscripts is that very often the results and the discussions get overlapped. Like, you can't tell where the results are ending and where the discussion is starting, or you can't tell where is the result and where is the discussion, and that makes your paper difficult to read. The first thing is that we need to know exactly what happened in your study and what is your analysis of that. So the results is where you are reporting what happened. You did an intervention, or you conducted some survey, or you analyzed through some data, and what did you observe? It is as simple as, it's like being a newspaper reporter. You report on the event as is. In the results section, refrain from giving any opinions or insights. Refrain from deviating too much from the observations. The purpose of the results is to report everything as is. Try not to give your insights, opinions on the results. That should all be left for the discussion, which we will cover in a bit. And to frame your results, a very useful site is this one. Oh, it's right here. equatornetwork.org. Now, this is a freely available site. It's a great platform because it has a lot of free resources, including templates, toolkits, frameworks, not just for writing results, but for writing various types of manuscripts, writing research proposals, grant proposals. It has a lot of those types of templates. So definitely check out that website. Here's an example over here. So these are the kind of templates they have access to. This is sort of like a flowchart that will help you determine which framework to use. So whether you need to use Consort, whether you need to use Prisma, whether you need to use CARE standards, you can get all of this information from this particular website. So it's a very, very useful website that you can use. Go into it, look for frameworks that match your study. So it's very simple. You go into it, you tell them it's a systematic review, it's a human study, it's an animal study, it's an original article. You give them the data and they'll recommend what frameworks, it'll populate what frameworks might work for your study. So, and here are some of the questions that you can address in your results section. So, what did the authors find? How did we arrive at that information? Has the information been presented in a factual and unbiased way? So make sure that the results section doesn't feel biased. It needs to be as factual as possible. Very, very important rule. Report all the results for the methodology that you've stated. Do not report any results for those methods that you've not stated. Your methodology and the results section has to have a one-to-one relationship. There are a lot of manuscripts where there will be many steps in the methodology, but then we omit the results that don't match our conclusions. Don't do that. If there are 10 steps in your methodology, report the results of every single step. If you can have literally a one-to-one relation where step 1, this was the result, step 2, this was the result, that's actually the perfect way of reporting your results. But if you can't do that, then at least at a high level, make sure that for all the methods that you've stated, you've also reported the results. If there are any results that you've stated but the methodology is missing or vice versa, that is a big reason for rejection, and that happens quite often. You know, we state results for which we forgot to report the methodology, or more often than that, there'll be a lot of steps in methodology, but we don't report all the results that were actually found in the study. So make sure that there's a one-to-one relationship there. And then the other point that I would like to emphasize is the discussion section. So again, if you go into Clinical Key, there are dedicated papers that talk about by subject area on how to write a powerful discussion section. So I would encourage you to explore that. But the reason why this is so important is because the discussion section is the most important section of your paper. Our advice is for you to spend the maximum time writing the discussion section. Very often what happens is people start writing the paper from introduction. They spend 10 days writing introduction. They use up 2/3 of their, so if their word limit is 1500, they use up 1000 words to write introduction. Then by the time you come to discussion, you have no time and space left. It should actually be the other way around. Write your tables, write your results, write your discussion first. Introduction is already there. It's there in your research proposal. You just have to wrap your head around it and rephrase it. The introduction is there. Focus on the discussion. When you start writing your manuscript, spend the bulk of your time, at least 2/3 of your time writing your discussion section. Spend a lot of space and thought writing your discussion section. Another thing that is advised is that the discussion section is where you should get as many inputs as you can. Reason being that the discussion section is where you should show your opinions. So all your thought leadership, all your insights, all your opinions, all the new information that you want to bring to light should come in your discussion section. Even if it's something like there is a treatment, you found that this treatment can also be applied to a new patient population. That's your observation. Now what are the implications of that? Does that mean that we are bringing a novel treatment to a patient population that has currently been underserved? Is this patient new treatment going to make it cheaper for these people to access that treatment? Is it going to help us expand quality of life, improve quality of life for these patients? All of these implications should be placed in your discussion section. There are other types of studies. So for example, there was one study where we were talking about the need for making nursing, making the observation of pressure sores in the hospital more evidence-based rather than intuitive for nurses. So in that paper, the discussion completely lacked that, okay, there is a need to make the process more evidence-based than intuitive. So what? Does that mean that you're going to train your nurses? Does that mean you're going to implement a software to capture that evidence? Does that mean you're going to have a new policy around it in your hospital? None of those implications were given. So that leaves the question of so what, right? If you understand that there is a need to have more evidence-based practice in managing pressure sores, what are you going to, or what are you proposing to do about it? Those are the sort of insights that should all go into your discussion section. The discussion section needs to be grounded in data, but it should also be the place where you bring new ideas. Don't bring ideas saying that, okay, the nurses should use an AI app to monitor pressure sores. If you want an AI app, then on what basis? What sort of AI app? Is there an AI app in the market to talk about these things? Is there a training program currently available to support nurses? Ground it in data, but bring all your new ideas over here. To help you bring those new ideas, it is very, very productive to get a lot of inputs from mentors, from parallel industries, from other co-workers on your discussion section. So wherever you're looking for research collaborations, and especially you're looking for people to be your mentor and not a co-author or an author on your paper, this is the place where you should try to get their inputs as much as you can, because it actually does help to get an outsider's perspective in the discussion section. So we have some tips over here. This is again things that you can use to frame your discussion section, tips on how you can write. One of the things which is very useful is to reference articles. So in your discussion section, you can actually use that section to think about how your findings are different from what is the current existing knowledge. So the whole point of research is to compare what is the new information compared to what is already existing. Do that in the discussion section. So you can refer to what is already published in your discussion section here. It helps to identify, don't have to refer to everything. We've seen manuscripts where they'll refer to 20 articles in the discussion section. That's also not productive. Identify those articles that are either closest to your study or those articles that will also help you get the right eyeballs. So if you're doing something which has also been done at Mayo Clinic and you're comparing it to that Mayo Clinic study, every time somebody's looking at that Mayo Clinic study, chances are that you might get a view or a citation as well. So be very selective. Use a few articles that you want to compare to, but it's a good practice to do that in your discussion section about who you're trying to compare yourself as well, right? And then finally, a lot of people have this, further studies are needed. I think everybody knows this is not a good idea, right? Why is it not a good idea?
It says your research is non-conclusive.
One, I think it's more about, okay, if further studies are needed, then why didn't you do the further study, right? Yeah. What's your next paper? It's not a bad thing to not get results, for example. But then, why, right? Why did you not try again? Why did you not try harder? If you do say that further studies are needed, then at least explain what are those further studies, why you couldn't do them at your institution. Maybe you need to collaborate with a larger institution to get access to a larger patient population. That's fine. Acknowledge your limitations as well, but don't leave it at further studies are needed. Why are further studies needed? That's the important point to cover here. And that is a good segue to talk about limitations. So, like I said, it's not a bad thing to acknowledge your limitations. It's actually very important that you acknowledge your limitations. In fact, those of you who've written systematic reviews will realize that it's almost mandatory to state the limitations of your study in a systematic review. So it's not a bad thing to acknowledge your limitations, but there's a way to frame it. I particularly like this example a lot because I'll highlight it to you. So the way they framed it is that the researcher says that we were underpowered. Okay. They did not adjust for potential risk factors. Second limitation. Third limitation, this is coming from a single center and cannot be generalized. Yet, the findings demonstrate the risk of an important comorbid condition that impacts survival and quality of life of children after transplantation. So the author has communicated that we had these three major limitations, yet our findings are impactful because XYZ. In this case, these findings are very relevant because they are targeting a very sensitive group. So children, pregnant women, children after transplantation, elderly people with certain medical conditions are considered sensitive groups because they have a very high requirement from a healthcare perspective, and there is not a lot of research on this topic. So the author has clearly stated the relevance of his or her research. That we did have these three limitations, yet it's almost like saying I still believe that my study is worth publishing because I have information about a sensitive population, or because I have information about a sensitive issue which has not been researched. So that's a very good way of framing your limitations, where you acknowledge them, you state them, but at the same time remind the reader that despite these limitations, my study is still relevant and worth publishing because of this, right? So these are some quick tips that you can all adopt. I'll conclude with this. The last part of your paper is the conclusion, and the best way to write your conclusion is by making it as concise as possible. The best conclusions are those that directly answer your paper title or your research question. So you can have a relatively long discussion, you can, with limitations, you can have a slightly shorter results section which justifies everything that you've done, and then conclude with as simple a conclusion as possible. So as you can see over here, this is still very long. This is a good one. So the title of the paper was Compression Stockings to Prevent Post-Thrombotic Syndrome, a random control trial. And the conclusion is as simple as this, that ECS did not prevent post-thrombotic syndrome after first proximal DVT. Hence, our findings do not support routine wearing of ECS. As simple as that. So, your conclusions should be short, concise, no longer than a single paragraph if possible. As concise as possible, those are the best conclusions that you can have. If you can directly answer your research question or your research title in your conclusion, that's the best, because it makes it so easy to read for everybody, right? And that brings us to the end of our presentation today. As you can see, there were a lot of links, a lot of bullets in the slides, so you can always go back to them. And we are also trying to make this a regular exercise where we'll have either on-site or webinar sessions with various Apollo groups to share more information. But if you're not able to do that, these are all links from Clinical Key that you have access to. You can always go into them and have a read. sites have access to. It's available at your site and via remote access. You can just set up an account and you will get information. If you would like to access, my colleagues Kishore and Abhishek are here. They can help you set up accounts, and I'm just mindful of everybody's time, so we can discuss that offline on how to set up access for everybody.
Other institutions also have political key.
Yes, there are many institutions that have access. So if not Apollo, if you have access from somewhere else, please, by all means. Any questions that you have related to clinical key, any questions that you have related to clinical key, AI, that's also coming up soon. Tim can answer
what
that.
about Chat GPT? How useful will it be in
Tim,
framing
this
our,
is your area now. Sorry, Chat GPT for research or
for framing our manuscript, for helping us in our manuscript?
that's a very risky question. So I'll attempt it a little bit and I'll ask Tim to talk about it, right? And we have a separate workshop on the use of, on the role of AI in research. We have a topic covering that which we can always conduct at a different date, but at a very high level, you cannot use ChatGPT to write your
It can
manuscript.
tell us that your tables are good or not.
There are many software to do that, and our workshop does cover. So there are many legit software, both AI and non-AI software, that can actually support you. We have a dedicated workshop that covers this, that what are the good software for proofreading your manuscript, good software for looking at the quality of your images and things like that. Yes, so I can send you some names separately. We'll talk and we do cover that. But to answer your question about
Do you have
ChatGPT,
something which you can share with us for proofreading or for
I-
coaching or saying?
I don't have it in this deck and I'm not using my device, but I'll add it to the slides or I'll just pass you my card. We'll share that with you.
Natasha, I want to say that I really enjoyed what you spoke about. I'm sitting in this class because I feel a bit ashamed that I've been a clinician for 25 years. I'm an ophthalmologist. I run a hospital. We have 7 more ophthalmologists working with us. We've not brought out the research paper till now. And I feel that everybody is so busy in their jobs and there's not enough incentive or reason, or I don't know what's the real cause why we're not doing it, but we would like to start doing it. I believe your company is solely working towards it. How do we collaborate and is there a way in which I can take it up? A professional way.
Ma'am, we would definitely
I think
love to.
Natasha will also answer this, and I will answer like you.
Please, sir.
Please,
Yeah.
sir. So,
First
pehle
you proceed.
ma'am, we can definitely take this offline. We'll connect with you separately. I'm sure there's something that we can do. We have a team, we call it the Clinical Best Practice Council. And in the Clinical Best Practice Council, we have dedicated people. There's a lady by the name of Dr. Elena Alvira. She's a medical writer herself, and she's done a lot of research and publishing, and she has a lot of experience in writing. So we can connect you to her and we can talk about what are the challenges that your institution has right now. Maybe they don't have time. Maybe they're not collecting data in a structured manner. Maybe they don't know that they need to do research to further their careers, or maybe they don't know how to start on a research journey. So it's important for us to sit down and understand exactly आपके institution में हो क्या रहा है, discuss it with our internal experts, and we can definitely work with you in this area. That's what we're here for. And Dr. Agarwal?
Thank you. First of all, thank you, Natasha. Thank you, Tim, and the LGV team for through Natasha making this wonderful presentation. I have gone through many presentations, and I have no hesitation saying that your presentation is one of the best.
Thank you, sir.
This is number one. Number two, needless to say that I like to answer your question.
Yes,
Oh,
I'm
my
waiting for that, sir.
That's very good. You said that you are into clinical practice for 25 years. You have a couple of colleagues with you,
Yes,
and
sir.
so far you have not engaged
Yes, sir.
with research.
That's right.
That is the normal practice. There is nothing new about it.
So that's yeah, please, sir.
There is nothing new about it. It is a question of you are working in a hospital scenario, you are working in a hospital scenario with some educational program? Are you working in a medical college scenario? Are you working in a totally dedicated research center? Right? I like to give an example of that. A good hospital, 100 bedded, 200 bedded hospital, having big rush, patient in, going out, all clinicians are very busy. Right? This is one thing. Then, as I told you in the beginning, that 200 bedded hospital decided that let us do DNB. The moment educational program were introduced in ophthalmics department of yours, suppose, then automatically you become a teacher. And the student who is working is supposed to do some sort of research work. So automatically you and your student can become the teamwork for the research. Suppose you are in a medical college and you need them to say publish or perish. The dictum is publish or perish. It's an old dictum. I think I have changed this dictum which I will be talking after 5 minutes now, according to me. So, in case you have a desire, then believe me, the research work, say in ophthalmic, need not to go for any high-end research. We need data. India, I always say, I'm glad that at this gathering we have our colleagues from Ayurveda also, and Mr. Rajiv Vasudeva and his team. You know, India's strength, I always say one thing, unfortunate suffering of human being in big numbers become fortune for medical education and research. Am I correct?
It's ironic, but it's ironic. But
It's sad. I don't want to have suffering around me or me to suffer. But what to do? When numbers are so big, numbers will increase suffering. And if numbers are increasing, as a medical student, where do we learn? We have learned in a medical college. We have learned in a medical college. My college was KGMC Lucknow, where OPD, indoor, flooded. Right? So perhaps that perception in my mind of seeing one particular ophthalmic condition, I like to remember by ophthalmic posting or cataract of different kinds. Yeah? So that is still in my mind. But at the same time, you can always pick up as simplest possible problem. Say, complications after cataract surgery. There are textbooks written about it, but your experience will add to it. I always say that collection of thoughts in terms of, suppose I want to say that collection of post of cataract surgery. I really wish that there should be a pan-India registry where 100 or 200 ophthalmic surgeons should be the part of it, together bring collective, and then that will become the document for the world, because nowhere in the world will have that much numbers. तो आप इंडिविजुअल रिसर्च कर सकते हैं, आप चाहें तो अपने को कोलैबोरेट कर सकते हैं, and think about simplest possible research. Don't go for complicated. Let the complicated research be undertaken by ICM, by All India Institute of Medical Sciences. But you, if you have a dream, you can. As regards the role of industry is concerned, yes, as like Algeria should also encourage. Algeria should also encourage. There should be a platform. Tim, where is Tim? Yeah. There should be a platform. Public health research. She can always be involved in public health. They are doing so many camps. The collection of data during the camp
Exactly. Tim, this is what we were talking about earlier. We've just started experimenting with this, and I myself am at that point where I need to show some public health work, which I just did to Dr. Jimena, and get her feedback on whether to write it into a research or not. So I think you and I are in the same boat right now.
So I'm writing some public health work this time, especially about the Ayushman Bharat Arogya Yojana that we have with the BPMJ, the insurance for that work.
Yes, I'm
So I have collected some data and I've already sent one paper that has been accepted. But I have some more data which I want to present in a different way.
okay. Yes. So I'll ask Tim to also comment on this a little bit, but the few tips that I can add is that there's a lot of resources available on public health research. If you're planning to write something, the first step that you should do is read what is already published. That will not only give you that knowledge gap, but it will also give you inspiration and guide your style of writing. So read what is already out there. There is a lot of information, resources from Elsevier, including Clinical Key, where you have this. At the same time, there are also a lot of journals that dedicatedly publish on public health. It's just that people don't know about those journals. There are a lot of journals that publish on public health, but they're not famous journals. So if you need information on where to publish, you can reach out to us and we...
Yes, I need that because one difficulty that I'm facing is that publication charges
Right.
are not affordable for me
Right.
because my institution is not supporting me for that. That has to be
Let's discuss that. We can definitely think about how we can work in certain these areas, and these are definitely topics which we will cover in future sessions. So how to identify a journal, how to think about publishing charges, how to address these kinds of needs for authors. We can cover this. Tim, did you want to say something on this
I was
topic?
just thinking about the concept of not knowing what you don't know, and whether it's possible to then start thinking. So the public health piece, we were looking in Clinical Key for specific information. So you put in a topic, say it's malaria, as we were talking about the other day, and actually you search malaria and you'll find 17,000 pieces of information on Clinical Key. You can narrow that down, or you can increase it by adding midline into that search as well. You
Yes.
suddenly get 25,000 pieces. But it's then using the ability to go through and sort to find information. But I think the interesting thing is it leads to new questions, because you read something in an article and you say, well, actually that's something perhaps I don't know about, and how can I go in? And we've talked about, mentioned artificial intelligence. We're just releasing a product in the United States called Clinical Key AI. ChatGPT basically lies occasionally, okay? And it's because it's looking for patterns and recognition, what it's likely to provide.
Is it
And
biased?
it can be biased, but it's also, it's basically, it's looking for information and then saying what's likely to be the next answer to that, in its best guess. Now what we've been looking at is something called RAG, so it's Retrieval Augmented Artificial Intelligence, and we give it a piece of subject. So for example, if you say I want to know what is the current treatment for malaria in southern India, okay? The first thing it's going to do is say, I've got a series of papers and articles about malaria. So that's my study piece that I'm going to look at. It then says, what's my question about that? Well, let's find the string of text in those articles specifically about southern India, about malaria, treatment, and then it narrows that down. Now, instead of having a best guess, you have an absolute string of information that it can do. Now, the beauty of this is it will return an answer, and it uses generative AI to answer the question. So what is the current treatment? What are the current drugs? But it then gives you some prompts underneath that says, do you want to know about, what should I ask more? What is the current resistance to chloroquine within the region of South India? What are the alternative drugs to chloroquine within that region? So you can start to ask questions about public health. And, what is the likely cohort of patients within that region who have resistance? And that then draws out the information from the research to say, this study perhaps found this number of patients who are resistant. So you can then start to say, what can I do with this now? could I find novel research that I could do in this particular area? But it's using the tool to investigate and bring questions to mind. And in clinical practice, we think it helps critical thinking as well, because it starts to say, well, what don't I know? What might I ask? And then perhaps give me some sensible answers. So ChatGPT is great at, it's great for writing emails and things. If you want some flowery words, if you want to make it useful. But you have to remember it's built on a probability of what is the next answer. We occasionally put information. I take an email and I say, this is the email structure that somebody's given me for a document. This is my document. Does it match what it says? And ChatGPT will come back and say, well, you've given a good article, part of this introduction. You might have missed something in this area. I recommend you update that. So it's quite nice to help me understand how I would improve it, but not using ChatGPT to write it for me. So it's good at analysing information. But I think these are all exciting technologies, and we're only at the start.
Before we proceed or finish, is there any other lecture in this hall?
Yeah.
After 3:30?
Yeah.
Do we want to know the price?
Yeah. So
One
thank.
question.
No, I
Well,
think
I
that
sort
one
of I sort of tell something to Tim is that a person like me, sir spoke about students who would come up with a research study because it's mandatory for them.
Yeah.
But a clinician like me, and I said I'm ashamed, 25 years. So there are 10 things which I would want to do research. I know the research questions. I need a research assistant.
Yes.
And I feel that a company like yours should come up with a very simple kind of a way in which to support us. So I know how do I make my manuscript, which journal can I put, what is my clinical key, what is the available thing available with, already, so stuff like that, I need help, I'm asking for help.
Well, we can
Such
talk
great
afterwards.
forms.
Yes.
It's a very good desire of yours.
Yeah, desire is good, thank you.
And
Do we have
believe
time
me,
for one more question, if you don't mind?
okay,
I think they need
I think such type of platforms are available, though you must know where to go.
Yeah, I think these two people are sounding very promising. I'll contact them right now.
Yes, a quick link.
Yeah, so basically I'm from Healthcare Global. We also use, all our centers we use Clinical Key. We've been able to set up a medical writing help desk, so to speak, where we do publish about 150 research papers at PubMed index levels, publications on an annual basis. So we have that channel streamlined like many of the publishers. And we also run the Journal of Precision Oncology, which is our own in-house journal, which does a double-blinded peer review process, open source, open access journal system. My biggest question is, how do I train my reviewers to do a good job? So from an editorial standpoint, how do I address my reviewers and ensure that they are addressing the situation properly? Probably an extension of this AI discussion that is happening in the market of late is how relevant is PubPeer and Retraction Watch becoming with regard to understanding how evidence is rolled back, so to speak, and how Elsevier or other publishers are handling this kind of discussion that is happening around retractions.
Absolutely, and retractions is again a topic which is very close to Himena, right? She talks about it a lot. So these are definitely things, as I mentioned, we want to do this as an ongoing program for Apollo, and we can definitely look at Healthcare Global as well. So these are exactly the things that we cover in our ongoing workshops. We try to do these as a series of either on-site or webinars, where we first we will ask you that, okay, if your challenge is to support your reviewers, then we will create a program customized specifically for that. And how can we equip your reviewers both with the training and the tools that are required for them to be more efficient. If your challenge is, getting started on research, then we'll work at that level and we'll create a program that supports you specifically in those areas.
Need a hands-on kind
That
of.
can be
Yes.
customized.
Yes.
So we have a lot of subject experts. So like ma'am said, that we have oncologists, we have medical oncologists who do immunotherapy day in and day out, and they are definitely subject experts on patient outcomes. They might not publish as frequently as we want them to, but we have picked them up as associate editors. And like she said, they don't have time apart from their clinical practice to do paper writing, nor do they have time to do reviews. So I want to know whether, if I've given a review to, as a reviewer, assign somebody, have they done a thorough enough job for me to understand if they're giving comments comprehensively?
Perfection will come great.
I don't think we have a software to detect that.
I know.
But we can always discuss and work on this together.
Before you people leave, thank you for your patience, but we have a small quiz. Natasha or Dr. Arun can ask one simple question to the audience from the topic, and one who will be answer will be receiving a gift from our side.
Dr. Agarwal अपने quiz करना है सबको.
वो तो मैं कर लूँ. Question करना है.
Any question, simple, any one of you from the topic, any one of you.
bias हो जाएंगे सर, आप moderator है ना, आप ही.
That's what I also thought. That moderator is on
Conflict of
my
interest.
Any question and the best answer would get a prize from us.
So how do we answer thing?
His choice. Moderators
और जो
choice.
क्वेश्चन पूछेगा उसके लिए भी है.
I thought to organize a team then.
I think it's a very good exercise because it gives us a positive thing. Now the question is that many a times, say at postgraduate India is such a big country, so many medical colleges, so many DNB, and every time the candidate comes, okay, what is the topic? What is the topic? And topic, some professors go and read that journal and pick up the best topic. That means he is told to pick up the already researched topic, right? And then obviously he or she will go and see that journal and he will find 2-3 important articles, take it to professor, and this is that. That is a usual practice. But personally, I also did it when I was there. But I think that should be changed. In what way can our youngsters should be told to pick up the topic? Yes.
So choosing a research topic would be basically not from the journal's point of view. I would say that you should be first involved in the clinical practice and what they feel the present treatment is and what the gaps between the present treatment.
Thank you. Moderator of the session, Dr. Michael Roderick. He is professor from Practice Medical Textiles at Shivaji University, Maharashtra. Dr. Michael holds an expertise in cross-platform knowledge, linking and medical devices regulatory and quality management. He is a pioneer in inventing and regulatory clearance of many unique designs and formulations in India. He is also actively involved in the field of research and development in technical textiles. Welcome, sir. I would like to also welcome our speakers for the session, Dr. Ranjita Adhikari, Dr. Mary Diaz, and Dr. Anup Warrior, and would request Dr. Michael to introduce the speakers and take the session forward. Thank you so much.
Thank you. First of all, good afternoon to you all and a very warm welcome. We had to rush out of the previous session and I was worried whether there will be enough audiences, and thanks, there were audiences waiting for us. So, as mentioned, I am Dr. Michael Rodrigues. I am the professor of practice, but I am a co-founder of a medical company called Kerala Medical Private Limited, Coimbatore, which is acquired by Healthier MedTech now. So, right from the inception, technologies that take care and cater to antimicrobial resistance had been always at the forefront of our organization's work. Today, tackling antimicrobial resistance in healthcare is a very global and alarming problem. It diminishes the effectiveness of antibiotics, which in normal course would be very effective. In short, we are fighting to preserve what we have before they lose their effectiveness, because unless we find effective alternatives, we cannot let this go. And the effective alternatives are too fewer and too short at present. So the entire aspect of AMR's tackling is around preserve what we have till we run out of the effectiveness of this. Today we will be having a very wonderful discussion for sure, and we have framed it in a different way. We will not be having any presentations here, but this is like more or less a question answer session, so that the eminent panel member here are able to share their experiences, thoughts and insights and their personal experiences, so that it becomes more of educative and informative section from their perspective on the subject. So before I take further ado and proceed on this, I would request every panel members to introduce themselves. So right from you, ma'am.
Good afternoon, and I thank the organizing members for inviting me to this session. I'm Dr. Mary Dias, Professor of Microbiology at St. John's Medical College. My main interest is in molecular diagnosis of infectious diseases. I am also heading the infectious disease unit at the SJRI, that is the Research Institute. I'm a teacher basically, and no microbiologist can be separated from antibiotics, which is the bread and butter of our daily existence too. So I look forward to being in this session and being part of this interactive module, which helps us understand combating antimicrobial resistance, whatever little antibiotics we have now, to be preserved, as Dr. Rodriguez said.
Good afternoon, everyone. I'm extremely delighted to be a part of this program, and I thank NetHealth for inviting me. I am Dr. Ranjita Adhikari, the consultant microbiologist and infection control officer of Manipal Hospital at the Old Airport Road, Bruns. I have been in the hospital for the last 15 years, and I look after the infection control practices, and happy to be a part of this program. Thank you.
Good evening. I'm Dr. Anup Warrior. I'm an ID physician with the hospital called Aster Medcity in Cochin. I have been practicing stewardships and running stewardship programs since about 15 years now, as an extension of my clinical practice more than anything else. And I have some exposure to government level activities, being a task force member for both the state of Kerala and also being a part of the WHO and CDC collaboration for the antibiogram and developing guidelines in terms of infection control. Thank you.
So you could understand today we have eminent panelists from different organizations. Not only that, they come from different strata of the organization, so you can have a better perspective of what is happening on the subject. And before I proceed with the session, I promise we have not met before, and neither we have discussed about this session. Basically, I met all of them first time on this podium. Okay, so it's a very genuine question and answer session, except that we had some discussion of the questions prior. Okay, so I have all the questions, okay, drafted well, so that we extract more information from this people. So to begin with, I would like to ask Dr. Adhikari to just set the perspective of what is this AMR and how big the problem is. What is that we are afraid of or scared of? So over to you, ma'am.
AMR, that is the antimicrobial resistance, is the ability of the microorganism to persist and grow, even in the presence of the antimicrobials which were explicitly designed to kill them. Now, why this is happening? It is only because of the extensive use of antimicrobials in the field of human, plant and animal. Because of the extensive use, there is mutation of the microorganisms, and because of the pressure effect of the antimicrobial agents, they flourish exponentially. Now, this problem has become a very big, and now we can say that it has become a silent global pandemic, and this pandemic has been increased many folds during the COVID times, and it has been growing unabated. Now, if you look at the problem, I come from a multi-specialty hospital. So in my hospital, when I isolate the organisms and do the antimicrobial sensitivity pattern, I get many referral patients as well. So the drug resistance pattern in my hospital is different E. coli and in Klebsiella. Klebsiella, we see more type of antimicrobial resistance. About 55% of the antimicrobial resistance we see in carbapenem, and about 6.4% for colistin. In E. coli, it is lesser, and it is about 12% of the carbapenem resistant, and only 0.65 is the colistin resistant as of now. But when I compare the data of the last year, because we do the antibiogram every 6 months, we found that the colistin resistance for Klebsiella pneumoniae has increased by 1%. So that is not a good scenario, because we get many patients from Northeast, from West Bengal, and these are all referred patients, and they are already on antibiotics, so they come up with all these carbapenem resistant organisms. This is alarming for us. And if you look at the global data, in 2019, about 4.95 million deaths were there because of the COVID, because of the antimicrobial resistance. This death is indirectly related to antimicrobial resistance because they were suffering from this type of organisms, and about 1.27 million deaths were there. And about 1 in every 5 cases were children less than 5 years. Looking at the Indian scenario, this is also alarming because there was about 2,97 deaths directly attributable to antimicrobial resistance. So this is the current scenario, and the problem is very big. We have to tackle it at the earliest.
Just to give a perspective from the patient safety side. So basically what this means is that your routine run-of-the-mill infections like a urinary tract infections cannot be treated with oral tablets anymore. Like even though you are not ill enough or sick enough to be in the hospital, you still need to go to get an injectable. So that's a patient impact. You end up with certain serious infections where we cannot as doctors offer you any new antibiotic at all, and we end up losing the patient because it is pan-drug resistant. There is actually basically nothing else which we can give to treat. So that's the impact on the patient directly.
Thank you, doctor, for adding the perspective to it. Because when we talk in perspective, then people understand, okay, rather than the numbers. So just to put some numbers also, so that I follow with the next question, is that there's a statistics in 1900, the average span life of a person was 47 years. In 1950, it was 68 years. In 2019, it was 79 years. Of course, all of that cannot be attributed to the rise of antibiotics, but yes, significantly attributed to the rise of antibiotics along with the advancement in medical sciences. So now my question is, what would happen, or what are the potential consequences that what would happen if we fail to cater or to curb this problem, and what adverse effect can have on the hospital and healthcare setup all across the globe and India particular? This again to you, Dr. Adhikari.
The antimicrobial resistance has become alarming. It has reached such a level that if we do not tackle it properly, it will be very difficult for us to treat normal infections. There will be increased hospital stay, increased healthcare costs, there will be increased mortality. Now we have to handle it at the earliest. Now how to handle it? In India, what we have seen is the over-the-counter, you can buy medicines without any medical prescription. This has to be stopped, and the patient awareness should be increased. Like patient awareness, like simple hand hygiene practices can stop many illnesses, and they should not take any medications without a doctor's prescription. The doctors also should have one-to-one interaction with the patient so that they are comfortable, because many times the doctors say that we prescribe medicines because the patients pressurize us. There is an erroneous perception that antibiotics will help them to relieve the symptoms faster. But we should remember that antibiotics are not magic bullets. We need to use them judiciously. So awareness is very important. It could be social print media, it could be awareness through the internet, print media, any type of public awareness should be taken at the earliest.
So do you mean to say that our average lifespan will go down drastically in the absence of any alternatives to the antibiotics at present? Or what would be the consequences?
The consequences will be that we will be left with no antimicrobials for treatment of trivial infections like the respiratory tract infections or the uncomplicated diarrheal infections. The first line antibiotics are no more that we can use it. The second line and third line antimicrobials are more expensive. They are more dangerous. They have got many side effects. So we are left with no, as Dr. Warrior said, that simple infections like the urinary tract infection, we cannot use nitrofurantoin because they are already resistant. Then second line drugs are, third line drugs are injectables. And we have to use injectables for a simple infection. This becomes a problem for the clinicians to treat simple infections.
Yeah, thank you.
Can I add
Yeah,
a little
please,
bit
please.
on that?
Yeah.
So you asked about lifespan and antibiotic relationships. So lifespan has increased not only because we have antibiotics, we also have so many newer procedures which have come, like transplants. You can increase the life of patients with cancers with immunosuppressants and immunomodulators. So what happens is that it will become a case of the surgery was successful but the patient died. Because you have the latest and the most technological advancements in cancer therapy, transplant therapies, which increases the lifespan of the patient, but ultimately they will die of a simple bacterial infection because of AMR. So definitely whatever gains we have over the so many years that you said that we have advanced in saving lives and increasing lifespan will drastically come down if we do not tackle this simple problem.
So I will continue with the question to you, ma'am. Says, how do you think is this AMR affecting the patients in different healthcare settings in your observations?
Yeah. So just continuing on what I'm telling, so this is what I spoke to you is in a large tertiary care, like suppose we're talking about hospitals like what Dr. Adhikari and Warrior are in. So they deal with big transplants and they have a huge tertiary care setup. And definitely AMR is a problem there for them. Not only for, I don't know whether they deal with both very simple infections which both of them spoke about will have a problem. There are definitely consequences even for a primary healthcare center or a nursing home or a teaching institution because we are all part of the same ecosystem. We are not drawn from different planets. We are on the same planet and the same patient goes everywhere. So it's in a primary care, if you see, they have already spoken about urinary tract infections becoming difficult to treat. So there you have the problem. In a tertiary care settings, small surgical procedures like a hernia repair or appendicitis removal, that will all save the patient. But if we have a drug resistance, it will alter them. Tertiary care centers, I already spoke to you about cancers and transplants and things. So no healthcare system is spared of this problem of AMR. So where you go, it will be there. Even OPD settings have a problem of AMR.
Yeah, it's true. So I go to Dr. Warrior now. Sir, can you please elaborate on the main contributing factors to the emergence of AMR? What is that has caused the AMR to be so much a problem today?
So, while inherent resistance or resistant bacteria has always been around, as Dr. Adhikari was mentioning earlier, what we call a selection pressure, whereas you pump in a set of antibiotics into the system, into the ecosystem in various forms, be it in animal husbandry, be it in human population, be it in the farming, etc. And then you exert this selection pressure onto these small subpopulations of bacteria who could have resistance, and then they cross-transmit and they get into the humans and cause health problems. So we, in terms of approach or practicality, we tend to divide them into inappropriate or excessive use in humans. And there is also a legitimate use in humans. The antibiotic use has gone up on one side because of the medical advancement. Because we are doing more transplants, we use more antibiotics. Because we do a lot of implants or complicated surgeries, we end up using this thing. Second is that, again, another example of legitimate antibiotic use going up is because we have poor hygiene. We have poor water hygiene or poor air quality. we end up with more respiratory tract infections, more waterborne diseases or gastroenteritis, which puts the patient in the hospital, and again they need to consume antibiotics, right? So there are scenarios where, because of various other factors, like in the community, as I was mentioning, the air quality, water quality, hygiene factors, and in the hospital in terms of advanced and intensive medical care which is provided, which pushes into more of legitimate antibiotics, which sets off the cycle, and it again increases the resistance, and then you end up in that vicious cycle. On the other side, there's a big chunk of inappropriate use of antibiotics, where we feel as that there is an opportunity for us to improve, where maybe the antibiotic was not required or did not be given, and we can withhold and hence reduce the pressure. But the important thing is, whenever we talk about AMR and stewardship or antibiotic consumption, the focus is almost always on the inappropriate use. But it is almost same, I mean, equal to equal. There's a huge chunk of this which is legitimate, and that also can be addressed by mechanisms outside what we are talking about, like community-based things like improving water quality and air hygiene, etc. On the other side is what you consume as what they call now as resistome. That means you have islands of resistant bacteria in the environment which reaches into you through your food and water. And that is another area where we are trying to address it in this, what WHO calls as the One Health concept, so that what you acquire from the environment, that there is a mechanism to look at that and tackle that too.
Yes, sir. Thank you. I'll just continue with you only. Just since you touched upon the point, what are the international efforts that they have been made to address this AMR and enhance the safety of the patients? Because we know the cause, but what are the international efforts that have been done in this?
So, globally, this has been looked at both at a governmental level at various countries, and also as a huge public health importance by the World Health Organization. The most of these activities initially are focused on the awareness, as we were speaking about, and also to try to promote interventions or innovations in what can be used to address or reduce this. Interestingly, there are also initiatives which incentivize innovations, incentivize antibiotic development, which is very critical now, because all what we talk about in terms of prevention, for that to be fruitful, even if you start doing that today, will take decades. Hence, getting new antibiotics on board to treat the patients who are sick or ill today is as important as looking at measures to prevent, so that we have something left for the future. So, at the global level, on one side, while there is a lot of initiatives in terms of improving the awareness and surveillance and understanding this problem, on the other side, there's an equally important effort in terms of how to tackle what we have now, that is development of antibiotics, and which we'll talk about later about what is beyond antibiotics and innovative interventions in addressing this problem as a whole.
Yeah, so since you have raised the point, so do you feel, Dr. Adhikari, that there is enough awareness in the Indian health sector, and is there enough teaching to the patients and the healthcare providers in India to tackle to this problem?
So patients' awareness is extremely low in India. Patients buy medicines across the counter and use it. That is called self-medication. Self-medication will lead to self-diagnosis, which is actually wrong. Mixed diagnosis will happen. Antimicrobials will be used when it is not required. Wrong antibiotic will be used, wrong route, wrong doses, wrong duration. Then the healthcare professionals also, when they are not giving antibiotics, they should have one-to-one communication with the patient, so the patient is comfortable, because they are self-limiting illnesses. That is why I am not giving antibiotics to you. But if the symptoms do not improve within 3 days, please come back to me, then we will do some other tests. So one-to-one communication is extremely important. And now the small agriculturist who uses antibiotics to increase the local production of poultry and the prophylactic antibiotics what they use, they should also be informed that the misuse of antibiotics is happening, which is leading to this antimicrobial resistance. That should be with one-to-one interaction with them, then it can be minimized or it could be stopped. creating awareness is important, but what type of awareness? Bombarding them with lot of information will create confusion. So choose what is required in that particular group of population. Simple measures like hand hygiene will prevent respiratory infections. Follow the respiratory etiquette so that you do not spread infection to others. Nutrition will improve the health of the patient. The immunity level will increase. Safe drinking water, good sanitation. These are the simple things, and then advise them not to buy medications across the counter, not to use medications which was used in the earlier infection. And many people have the habit of keeping the antibiotic safe so that if similar symptoms appear, they use the same antibiotic again. And if they feel better, when the course of antibiotic is given to a patient, they will use for at least 2 to 3 days. If they feel better, they stop the antibiotic. That should not be done. Antibiotics should be taken at the right time. This type of awareness, if it is created, I hope people will improve and the patient awareness will increase.
True. I think, please, yeah.
I just wanted to point out 2-3 examples which, see, in my mind was a huge success in terms of spreading awareness. The most recent one is about cervical cancer and human papillomavirus. So, since the HPV vaccines, Gardasil has been launched in the market, we are having a vaccination program in my hospital. Barely in a week, 2 or 3 people used to come, sometimes referred from the gynec. They used to sometimes look at the cost and walk away. But after the Janvi Kapoor's ads started coming and all, there's been a remarkable increase in people who come asking walk-ins. It's not even referred from OBG. They are walk-ins asking, proactively asking, do you have this vaccine? Can we get this vaccine? The second, obviously much older example of a very successful government program, the Pulse Polio, which Amitabh Bachchan came forefront of, was bas do boon zindagi ka, and how successful this was. So the awareness programs which you are looking at in terms of, it should not be spoken by doctors and all. That's not going to catch anybody's attention and ask to make anybody seek information or come to us. All good awareness programs in public health, etc., have taken this approach of getting celebrities, going out there to the public with people who they care and listen to them. So the other part again in terms of awareness was an example of what happened during COVID. During the COVID, lot of so-called rules and regulations, etc., were all thrown to the wind. Right? Things happened fast. We started making PPEs fast. It became notifiable, right? Even for a report, the ICMR. So, notification of an infectious disease was enforced very well. Okay. In terms of innovations or developments or policies, so the approval of the vaccine. So, even now for a new antibiotic, we have to wait for years, 5 years, 6 years down the line. While for COVID, the vaccine came just like that. So, there is an accelerated approval process. So, a lot of rules, etc., were in understanding the emergency of the situation. Both government and private, they could actually act and react in a very successful way. But unfortunately for AMR, there is no hurry. Nobody is showing that kind of panic or that kind of reaction this thing to AMR just like what they had in COVID. That's again a bad perception level. It's like global warming. Something aa raha hai, so do saal baad tab dekha jayega sort of thing.
This is a slow demon who is spreading. So anything that is slow catches attention at a very later stage. Yeah.
Just one more thing I want to add to what both of you said. In terms of awareness, now since Dr. Varia brought about the COVID also, taking the cue from the COVID, the government has done quite a bit. Like, how the COVID or the pandemic module was, I'm coming from a teaching institution, so I will add that perspective too. So COVID was brought out as a pandemic module in the students' curriculum itself, to how to tackle, how to understand, how vaccination came, all those things came up. Now they have brought a module on AMR itself. So there is, antibiotic stewardship has become a very important part of their education, because catching doctors when they are young is very important. Maybe as a microbiologist or as an infectious disease person, we understand that it is an impending bomb waiting to explode. But the young doctors won't understand because they are so carried away by transplants and the levels of what medicine and surgery can reach. But they forget the actual this thing. So government has taken up this method of educating and making people aware. So if you start young, catch them young and watch them grow is the point break, right? So government has come up with these kind of things. We should appreciate those things coming up now.
Yeah, government has surely come up. But what Dr. Warrior was saying is mass public appeal. Probably like in our South, Rajni had the same what Amitabh Bachchan did, and that has a mass appeal. If some celebrity comes and talks and we run a program of AMR saying, don't do this, this is killing us, and this is, probably that can make and change. That's what doctor had to say. So ma'am, just I come to you again. We heard so much about the One Health approach and all this in tackling AMR. Do you think that really works? What is your experience on that? Or are we prepared to accept that, or it is too early for us at present?
So One Health basically reminds us that we are not independent. Animal health, plant health and human health along with their environment is totally collaborative, one with the other, and one is not exclusive of the other. So if something affects the animals, very soon it is going to affect man. We saw it with COVID only actually. So we know that it probably came from the animal. And there are so many antibiotics which are commonly used in animal industry, like tetracyclines, triazoles, streptomycin. This is used both in all in agriculture, animal husbandry, as well as in human health. So antibiotic usage creates resistant bugs which can move across these three cycles of the entities which are there in the environment, creating problems for each other because they enter the food chain of each other and cause problems. Second thing is that, as Dr. Vari was also already mentioning about poor air quality and sewage and all those things, create niches for resistant organisms. So incomplete treatment of sewage, especially in countries like low-middle income countries like India, where the sewage water contains huge amount of organisms, be it drug resistant or non-drug resistant, which contains disinfectants which are coming from the hospital, waste antibiotics coming back from the hospital. If they are not tackled at the level or the source, they come into the public stream. So there are lots of studies which show AMR bacteria present in the water, even if there are no hospitals situated around. So that means it is coming into the thing. So they will move into the plants if you are using this water for irrigation, or get into the water system which we are drinking. So they easily move among all these things and cause problems to one. So if the one end is not tackled, if you are only worried about what we are doing to humans, we will be left with no option but land in a big problem. So that One Health is really important for us.
Just to again one part to the One Health thing. So what has happened is that when we have clinician conclaves or clinician based meetings where the antibiotic use etc. is being discussed, unfortunately this One Health becomes a way of pushing away the responsibility, so that it's used in pigs, it's used in plants, so why are you just talking to us? But the fact is that the major contribution still is human use, and there is an excellent example of that in Europe, developed Europe, where Netherlands has a huge consumption. It is the country with one of the highest consumption in pig farming, antibiotic use in pig farming, and also azole use for other rest of the plants and other growth. However, the resistance rates are least in Europe, in spite of having highest antibiotic consumption among animals. That is because their consumption among humans is least. So One Health and all is fine, there is a sector to deal with that etc. But as people who deal with human health, it should not be an excuse to push away the responsibility. There is a clear thing that human use or whatever we consume remains one of the most important and the most important factor of contributing to resistance.
Yeah, but adding to that, both in Netherlands, so they started right in 1990. They understood that there was a concept of One Health, and they brought in policies to look at what is used here, and they put in this understanding of this whatever happened into policies. And they have seen a reduction in the AMR. So it didn't happen that only humans reduced and therefore there is a thing. they looked at it in the One Health perspective. They actually looked at it as early as 1990s and brought down the levels of AMR in humans currently.
True. We have to understand humans, animals, and environment. All these forms, they change, wherein nothing can be left untouched. They are all a part of One Health. So thanks for that. We migrated up to One Health, but we didn't ask a very pertinent question, No, I'll take it to you, ma'am. That how do you describe what is the role of healthcare professionals here in India in promoting the responsible use of antibiotics? What are they doing? You said yes, there is a need, but what are they doing in your observation? What is happening? Do you think everything that needs to be done is done, or is there a very big gap till today?
So this role of antimicrobial stewardship comes here. The antimicrobial stewardship is a multidisciplinary team, and there should be a chairperson for that. The chairperson should be the hospital director. His main responsibility is to overlook the work done by the team members, and he should drive the work of the antimicrobial stewardship. Now, who will comprise the team? The team should be, it all depends on the resources available and the clinical setting. If you have an infectious disease specialist, he should lead the team because he has got good knowledge on the clinical stewardship, and he also has some amount of knowledge of infection control and diagnostic stewardship. So he's a very good person to lead the program. Next comes the infection control officer come clinical microbiologist. Clinical microbiologists hold the position of the infection control officer. So now for them, they have good knowledge about diagnostic stewardship, so they know which particular specimen should be sent for if the physician is looking for certain type of infections. If you send a swab sample, that's not a good sample. So the clinical microbiologists should guide the physicians the appropriate sample collection. They should report the correct organisms, not the commensals or the contaminants. Then they should work on the antibiogram development every 6 months or every 1 year and look at the resistant pattern, have one-to-one discussion with the physicians, and then do the antibiotic policy of the hospital. Next comes the clinical pharmacists. If they are there, you should take the help of them because they are the driving force in the background. They will do all the clinical work like monitoring of the prescription. This is one big job they do. Then they do the drug-to-drug interaction, whether the drug was given appropriately at the correct time, whether the right dose was given, whether there was any de-escalation if required. So they are the workforce behind the stewardship program. Now, if you do not have a clinical pharmacist, you can train the infection control nurse in stewardship program. So they are the main driving force of any healthcare facility. So they should be trained well. Now, if the ID specialist is not there, who will do the job? You can get the internal medicine physician trained in, especially in the stewardship program. They can overlook the program. So in my hospital, I'll give the example of my hospital. I have an ID specialist. I have a clinical pharmacist. But then there's an infection control officer. The leadership team, the medical director, he overlooks. So what we have started is that we have restricted certain antimicrobials use. So when a patient comes to the hospital, we have not said no at the beginning. You can start if the clinical condition warrants, if it is required, start with the high-end antimicrobials. Send cultures before the starting, and then one form is there which needs to be filled up, and it should come to us. And after 48 hours, we will look at what has grown. Then that forms with the laboratory report goes to the ID specialist. ID specialist then goes for rounds, have one-to-one discussion whether de-escalation is required, what if anything can be then shifted from the IV to oral. So we have done it that way. I hope if somebody else has got better experience to share, it will be nice.
Yeah, I will ask the question in addition to this to you, ma'am, to Dr. Dias. In short, what you said is an interdisciplinary approach. It's the patients, the doctors, the microbiologists. I would include the policymakers also. Actually, their stake is also very high here. And even the medicine companies, pharmacies, device manufacturers. So there has to be an interdisciplinary approach to tackle this. No one can be left alone, because this battle cannot be won by leaving someone alone, because then that will be a problem in pushing us down again in the battle. So my question to you, ma'am, in this interdisciplinary approach, so how can this interdisciplinary approach be enhanced? So what's your take on this, ma'am?
Yeah, so interdisciplinary in terms of antimicrobial resistance. Already we spoke about One Health, right? So we already know there are so many disciplines who are this thing. So probably a clinical microbiologist or somebody who understands AMR cannot go and ask an animal husbandry person to come in, or an agricultural team to come in. We may not have that kind of mandate. So it has to start right from international or national. International, we may not be able to have such a good, a draw, because we are bound by our country's rules. So usually this kind of collaboration starts at a national level. So in a national level, so if there are bodies like the NCDC, which is there in India, which is the one which collaborates all kinds of collaborative efforts among different bodies to bring in people to make this one. And then bodies like ICMR, which brings in medical colleges, research bodies together to make and understand. Then there are research bodies itself who have collaborative efforts, like the CARBA-X. I don't know if anyone knows. It's a collaborative which brings in interaction between people who make newer antibiotics or diagnostic platforms, which goes a long way towards combating AMR. So it's kind of a platform which helps them bring it together. There are a lot of public-private partnerships also which are there. To give an example, in India, the India Health Fund, they mobilize a lot of private sectors to bring in research collaborations to find out, if anybody has newer techniques or newer methodologies of diagnostics which can move into bringing. So all these bodies, including bodies like the National Body for Family Health and Family Welfare, so they too hold, collaborative programs for people, doctors, public, everybody, so that they, come in collaboration to understand. If you go to the global level, organizations like the WHO, which is the World Health Organization, have collaborations with food and agricultural organizations, animal health organizations. They meet together to understand what is the perspective of these kind of issues of AMR happening in different areas, so that they can bring in these policies and make it open for public to see and understand.
Thank you, ma'am. See, interdisciplinary approach, why did I bring this point is, in a very layman's language, as this panelist pointed out, they are taking antibiotics by getting it over the counter. Now, just like in headache medicine, like 2 medicines or 2 tablets or 3 tablets, something like that. Now, unless the pharmacy as a whole is on board, or the regulatory as a whole is on board, this won't be successful. So the interdisciplinary approach also has the regulators to have the regulations saying over-the-counter prescription should be encouraged, or unless otherwise it is recommended. So something like that. So I come to you, Dr. Warrior. Now, what are the emerging trends in the field of AMR today? So what is the hope? What is the way that we are fighting or hoping to fight?
So before I go on to that, I just want to one statement on, like you asked, what as healthcare professionals, what we can do, or what all of us here can do for the AMR thing. So one simple thing which does not cost much or anything is that next time you have a sore throat, don't take azithromycin. Everybody, forget about over-the-counter of patients. Every doctor, nurse who works in a hospital, every time you get a sore throat, they take a azithromycin. Again, going to the what's happening.
Actually, doctors are also the bigger part of the society. Okay.
In terms of the focus in AMR research, predominantly now it is on interventions that can be scaled up. Okay, so previously, last decades and etc., there was a lot of money being pushed into. Even now, when we look at research proposals coming, they talk about more of surveillance, understanding the burden of the program or the problem, etc. So that part is done. We we are clear on what is the burden. So that's not where we want the research, etc. to go. The research now and the focus now is on looking at what are the interventions which have been tried out. Can you think of a new intervention which can address this problem? Is this intervention something that can be scaled up across, can be used in different scenarios? That's where now the funding and support for research is there. So when you write grants and proposals related to AMR, and there are a lot of agencies around the world and the country who are there now ready to support. There's a lot of money in these grants who comes, but if you want to approach and get those, you need to have this kind of thing, an intervention that is likely to work, some trial and trying out something which is potentially scalable and can be used in different scenarios. There are also a lot of focus on getting away from antibiotics into non-antibiotic type of therapeutic options for a lot of infections, because whatever antibiotic you discover or innovate, or that couple of months to years later it's going to be a resistance anyway. So they are also looking at ways and means to avoid that track and take a different track in managing infectious diseases. So these are the two major areas in AMR and managing resistance which are in focus now.
Thank you. Since you mentioned about the robust surveillance system, I would like to ask you, ma'am, what is the importance of this robust surveillance system in tackling AMR?
So surveillance and understanding of what is prevalent is most important before we actually put an intervention. So unless we have data, we can only perceive and think that, oh, there is AMR, and start doing something about it. So what is this AMR? Where does it exist? So, it is very important that surveillance, meaning you need to capture data. So data is important for everything. Actually, that is the cutting edge, if you ask me. If we don't get data, we will never have an early warning system that something is coming. Because example, if I give you, it's like this, the CDC was the first who actually predicted the emergence of carbapenem-resistant Enterobacteriaceae. So when they said that, we didn't even imagine that meropenem resistance would come, and they picked it up. So that is an early warning system. Then because of this surveillance, we will have good understanding of, only if you know what it is resistant to, can you have policies, because if you want to put an empiric treatment, who can give you guidelines? Only if you know what is in the background is when you can actually. So what happens is that when this data is fed into a good database, people can pick it up. Like ICMR has now made the national antibiotic policy, which you can follow for different kinds of infections. This is all coming only from data. You cannot assume that something and create this thing, because it has to be evidence-based. If it is not, evidence can come only from data. So it is really important that we do this.
Is there any challenges at present with this data management system?
Absolutely, because especially in countries like, we can talk about India, forget about India, we can talk about our own hospitals. So if we talk about our own settings, if you see, data will be collected from different hospitals. Different hospitals have different kind of laboratory setups, different kinds of laboratory information systems, how they feed in data, what is the kind of data they are generating actually, who enters this data. So there is no uniformity in this data which is coming out. So it's very difficult to pick up and actually sift through this. Huge amount of resources go. And then we have antibiotic use in very local settings like in a village or in a district hospital. So there may be nobody to enter that data into a system. So where the antibiotic is being used, we do not have that data coming. So there is a huge challenge of these kind of non-uniformity, non-entry of data, different laboratory setups. All this go a long way in creating good data which can form a strong evidence for actual policies happening.
Thank you, ma'am. So we know that early detection is also very crucial for handling this type of emergence. So, Dr. Dias, I would like to ask you, what is the technological innovations that are happening at present in terms of diagnosing of the infections? I would like to answer that question.
Diagnosing of infections. Yes. So before antibiotic stewardship, diagnostic stewardship is very important. So actually, if you do not know what infection, what is the infecting agent, how will you even predict what antibiotic to use? So before, like Dr. Adhikari was telling, before you actually put a patient on an empiric antibiotic, it is so important to get a diagnostic sample out and do the testing. But if that diagnostic test itself is faulty, then you do not have this thing, right? So there are huge developments which are coming. We can talk about, I don't know, TB, you know. It has become so important because MDR became a very big problem in TB. That is why the innovation came about, a simple test like the Cepheid, which has the CB-NAT test, which can be done at the field level. So POCT test, which can actually detect genes of resistance, which is becoming. If you take into a larger perspective, now bigger tools like, you know, even genomic sequencing has become quite affordable, you know. So these kind of things have become what is a niche area where research is being done, and you're getting newer diagnostic tools which can identify agent immediately, like if you're taking a CSF sample, multiplex PCR, which can actually detect the bug, therefore start appropriate treatment. You can detect the antimicrobial genes, and therefore appropriate drug can be incorporated into his treatment regimen. So these kind of technologies are becoming very huge in diagnosis to help understand which organism and then institute the appropriate therapy for them. And also this will provide a good data as to what is the actual infection in this area, you know, what is the actual bug in this area. That also goes to data.
Thank you, ma'am. Would you like to add? Yeah, that's.
So the another area where this, in terms of diagnostics, which is being looked at, is host response. Because we know one of the challenges in clinical practice is to differentiate between a viral fever and a bacterial infection and non-infectious systemic inflammatory response syndrome to an infectious systemic inflammatory response syndrome. So in fact, last year or so, there was even been an FDA approved system which looked at your genomic response to various kinds. So it looks at multiple markers and gives a score based on which, you know, viral versus bacterial versus no. So on one track, while the diagnostic runs upon detecting the pathogen, there is also a parallel track where people are working upon to identify difference in host response to different infections and thus decide whether antibiotic or no antibiotic.
So I would continue with you. What is that now we have as a technological innovation in treating the infections?
So other the known antibiotic options, as we mentioned earlier, so of that, some of the things which are promising are one, we are looking at certain vaccines, so against E. coli, Staphylococcus aureus, etc., which causes severe recurrent problems. So people are looking at, and there have been reasonable successes also, though not to the thing of use or into the market. So vaccines are one way, and vaccines, not the traditional concept of vaccines that you take at childhood and you don't get something, but in terms of actively managing problems like recurrent urinary tract infections in people and all. So that is one area. Second is in terms of bacteriophages. So bacteriophages are again an interesting part where again there are centers in India itself who on a trial basis who have used it. ICMR has got a huge, it has got a plan now in terms of how to collect data for bacteriophages use and how to bring up guidelines on how it should be studied and used. So that's something which is again very near and is used in many centers now, bacteriophages for MDR. So other than these two, rest of them are a little far away. Okay, bacteriophage is something which is there right now, which you can access if you want to now, and vaccines are something which is in the near future, but you can't do it right now. The rest, like peptides and nanoparticles, etc., are right now just on good to read papers. Not
they are moonshots.
Yes.
So, Dr. Adhikari, would you like to add something on the diagnosis and the treatment with the AMR?
Okay. So the conventional, when the doctors send a sample, physicians send a sample, the conventional culture method. First day we will inoculate on the plates. Second day microorganisms will grow. On the second day we will be able to put up biochemical reactions and sensitivity. So on the third day we look at the organisms, and as per the CLSI guidelines we report the sensitivity. So how much time it has taken? 48 to 72 hours depending on the growth. So we have lost 3 days, 2 to 3 days. Now in the diagnostic stewardship, if we can bring new innovations like multi-TOF, the second day itself we can identify what organism is this. So we can inform the physician it's a gram-positive cocci, gram-negative bacilli. So accordingly they can streamline the antibiotics. Now there's something called filimare, biofire filimare. In that we have the blood culture bottles, samples coming in blood culture bottles for bacteriemia infections. We inoculate, we load into the bacterial machine, take out the blood culture bottles after 8 hours, and then load that sample into the filimare, and then we know what is that, whether it's a bacteria, virus, parasite, fungus, we know that much of information can be given within 10 hours. So gram-negative bacteremic infections can be given within 10 hours by using the Fill-Ematter method. So these are the two very good innovations that we have. Then the other one is the Carba RSA, which you can use in the Gene Expert. We know what are the genes that present, and accordingly we can modify the treatment. So I also like to add one thing. Azithromycin, we have misused it during the COVID time also. COVID time, nobody knew the actual treatment protocol. We were using left, right and center azithromycin, although it was a viral infection. Now what I see as a microbiologist, rising MIC for azithromycin when we report for enteric fever. It was not that bad before COVID. Now MIC is rising and we have started reporting azithromycin resistant. That is not good.
Surely it is not good. I think we are coming to the end of this session. We have the limitations of the time, and we have some time for the questions from the audience also, if something is unaddressed or remaining. So before I conclude with the session and go to the audiences, I have a very special question to all of them, and individually they can answer it. So if you had a power to change something, okay, in the existing system, what would you like to change and why? So I start with you, ma'am, no problem.
As a microbiologist, I want to improve the diagnostic system in India. There are no good laboratories to report correctly the causative microorganisms. So what happens? The doctor will use a broad spectrum antibiotic, and that is one of the main causes also of antimicrobial resistance. So diagnostic stewardship laboratories should have a good microbiologist, and the technicians should be also trained to handle emergency samples all round the clock. And also the infection control protocols of the hospital. You should lead an example by yourself. Wash hands, follow the respiratory etiquette. Do not eat food outside. Cook your own food at home, so that these are the simple things that you can prevent infections, and then you will not use antibiotics. Lead by an example.
Yeah, sir, for you. What power? You have a power, okay? Now you have to exercise that power. What would you do?
So I would recommend managing MDROs like how the government is doing for TB now. Make it notifiable, report deaths, and have like what we do in our state, maternity mortality audits, etc. When there is a maternal death, there is an audit which the state committee does. So the MDRO should be handled by the government in similar fashion as TB with death audits.
If I want to change something, it will be data sharing. I feel data is power. Unless you know what you are dealing with, you can never put any kind of thing. So because what I feel is that, to put something as simple as what you already have just onto a system. So if you have even 10 hospitals sharing their data from each of those, you can just make an empiric panel. So that itself will save your greatest antibiotic. You can preserve what you have. So we can start at the most simple thing without too much cost is actual data sharing, without fear. Like, most of the time data sharing doesn't happen because we are worried how bad we will look. If St. John's has to share this data, maybe St. John's look very bad. Okay? If Karnataka is sharing this data to the rest of the India, we feel that Karnataka will show in a very poor light. If as India we are showing it to the international, we feel that it will affect health tourism, it will affect that. So just that fear of sharing the data is actually inhibiting us from, which is the greatest and most powerful tool for tackling AMR. If we need to have this, because unless we see trends, we cannot make changes in our empiric policy. So if that doesn't happen, it will be very fast. See, by the time a new antibiotic reaches, by the time a new innovation for treatment of some wound or UTI reaches, by the time the vaccine, except for COVID, reaches us, or a diagnostic tool reaches with accurate sensitivity, specificity, which is required to diagnose as an infection, they are all very, very expensive. According to me, the most inexpensive which we can put is data.
This is the beauty of human mind. See, we had the same problem when we started the discussion. We had elaborate discussion on the aspects, right, from what is AMR to what is happening and who is contributing, what should be the way. And when these three individuals had a power to change, God-given power, they had a different perspective of changing it. But ultimately the goal is the one, okay, catering AMR. So with this we are coming to the end of the session, but the organizers have informed me that there will be one question asked to the audiences, and the correct answer would get some gift hamper. Okay, so this should have been announced at the start, so that some dropouts would have been avoided by them. Anyway, so the floor is open for the question answers to the eminent panelists. You are please welcome to ask the questions.
Yeah, it was a very wonderful discussion from all of you. It's really enjoyed. I have a question to Dr. Warrior regarding, so as we know recently Kerala government has introduced, regarding again to rationalize the use of antibiotic, sort of a without prescription antibiotic will not be dispensed, It is a new initiative. Can you throw some more light on that? How much it will be effective and what do you think?
So basically what the government of Kerala has done is that this concept was always there before, but what in terms it has named this program as Amrit. What it has done is that there will be inspections of pharmacies, unannounced inspections of pharmacies, and anybody, there is a number etc. which anybody can call and complain and say that this pharmacy is selling antibiotics without prescription. So either on an inspection or on a complaint, if it is identified that a pharmacy has sold without prescription, the license of that pharmacist will be cancelled. Okay, so that the thing that you should not sell was always there, but they have now tried to implement it on the ground or make it implementation better by one giving a channel of communication for complaints by lay person or any this thing, and also by setting in a system where there will be inspections to identify variations. With that, we are hoping that.
I hope the other states also copy this, Something good has to be copied.
But again, loopholes can be there.
Yeah, the second, because we bought the state of Kerala, so I will like to tell a second initiative from the state of Kerala. So what we have done is that there is a concept called smart hospital, antibiotic smart hospital, where it is expected that when you look at your sales of antibiotics, at least 80% or more would be in the access category. Okay, so this is, we are talking about primary and secondary care. This is PHCs and community health centers, and those we are not about quaternary care where we can't hope 80% would be amoxicillin or something. But so in each, so they are aiming at one antibiotic smart hospital in each district. Already 2 districts, Trivandrum district and Pathanamthitta, the 2 districts already have got community health centers who have been announced as antibiotic smart, because in the total sale 80% is access.
Someone wanted just a similar line question I had. Like narcotic prescriptions, we have a very stringent legislations. So if we go antibiotic wise, at least throughout the country, will it help any time?
Yes. So one of the from the central government, one of the initiatives was to change that schedule to Schedule H. But like what you told, still it is not up to the level of the narcotics. As I was mentioning about TB and MDRO, similarly, that is again a policy decision which I think that would be very much useful. Just like how for managing clinical management, making MDR notifiable will be there. Similarly, in terms of addressing prescription overuse, making it at a similar category narcotics would help, especially the reserve category of antibiotics, not the whole.
Okay, ma'am.
Thank you very much. That was in fact an excellent presentation. Of course, I'm familiar with those people on the dais and this is expected of them. I have something very, I would say, basics, and that is a lot of things that we do now in quality, whether it is safety and every one of them, we say, why was it not started when you were a medical student? So my question to all of you is, why do we not think that start introducing, we now are thinking of safety because the moment the student comes and becomes a clinician, he has watched probably the best and the worst, and thinks that to be a best surgeon you need to throw a scalpel on the floor. So similarly, why don't we introduce that in some way, in a small way? It's going to take time, it's a government policy, but I think a student who is there, at least during the pharmacology, should know and get introduced to this word of microbial resistance. I don't think I'd ever heard about it till I became actually an administrator. And working with Ranjita, I learned, I think, more of resistance than from anybody else. So that's all I wanted to say, that sometimes we need to look at the basics.
Now, the new CBMA curriculum by the NMC, I'm from a teaching hospital, so I'm just telling, this has been introduced from the last 3 years. The new CBME curriculum, that is the competency-based medical education. That is what has become the MBBS training now. So in the second year, when they are with us in microbiology, antimicrobial resistance, antimicrobial stewardship program, pandemic modules, all these have been put now as a mandatory training as part of one-to-one learning, small group discussions, seminars. All these have become very, very, like, catch them young and watch them grow. So that has come now into the medical system.
So I think probably in another couple of years or more, when you are going to have the conference, you might have lesser number of resistance, because you will have these people who have matured and become clinicians. And finally, it's easier to deal with these clinicians who know something rather than the present lot. At least I can vouch for that. Thank you.
We hope so, ma'am. We hope so, because this all comes from changing of human behavior, and that is the most difficult to change, actually. So once that gets instilled in them and understand that it is as important as treating somebody to change his heart or brain. If you change the heart or brain, but he'll die of an E. coli infection, they will not get that. I hope it will make a change.
Thank you.
Thank you, ma'am. Last question.
Thank you, sir, for the excellent discussion. Actually, I wanted to know, is there any guidelines, or can you throw some light on de-escalation principles, de-escalation of antibiotics? Because suppose a person in the ICU, a patient in the ICU, he is on high-end antibiotics, patient is doing well, then the clinical symptoms are okay, the clinical biochemical parameters are also well. The moment we have encountered certain cases, like the person, antibiotic was de-escalated and again the patient collapsed.
So, escalation, de-escalation, etc. are all standard clinical practices. Okay? So, they are all has to be taken and managed on a case-to-case basis, because these are clinical decisions. These are bedside clinical decisions, and the literature on de-escalation and the evidence on de-escalation, all in terms of outcomes, are not that great. Okay. So right now, from the ECMED, etc., the algorithm for de-escalation starts with asking first about the sample quality, whether you want to consider the sample as relevant to the clinical syndrome you are treating. Because initially the thought, and in many programs it's thought that there's a culture, you have to act upon it. It is not like that. First you have to link that culture to the patient. Only if that link is relevant is there any point in basing your decision on that. The second is on what is the expected duration which you are going to use that antibiotic, because the gain in resistance is based on the duration. So again, in the ECMED, the literature, they suggest that if the antibiotic duration is going to be short, there is no point in exposing the patient to a different class of antibiotic for the sake of de-escalation. So anytime you start with a stewardship program, etc., this is one of the most challenging areas, because it is a bedside clinical decision on whether to take that as relevant, not relevant, whether to act, etc. The diagnostic certainty is what determines whether you react to that culture or not. And hence, as I told, there are a lot of other aspects of stewardship which are more straightforward, which are not controversial, which are not subjective, based on the bedside assessment, etc., where we can focus.
So just an example of what Dr. Warrior just said. Now, diagnostic sample is so important. I can just give you an example of what happened yesterday in the hospital. So we had a blood culture with Streptococcus dyseglectiae. It's a beta strep. So went back to the patient. It is actually a patient who had cellulitis and then into blood culture. So there, penicillin is the drug of choice. So if you have that organism which you know that is the drug of choice, and you know definitely that is a causative agent, the patient was on ceftriaxone, it has to be brought down to penicillin. But if you take a bowel sample, okay, patient is bad and you have collected a bowel sample and you have grown Acinetobacter, and then some
environmental thing you got and there was a very sensitive organism, patient already is on carbapenems. To de-escalate, you might have to take a second time because that sample may not be representative of that clinical symptom for that patient. So there, that understanding of what clinical sample, does it represent that infection that patient is having is very, very crucial. A dialogue is always important. You cannot have a set policy. I will de-escalate to this level on a random basis.
Thank you, ma'am.
Thank you. So, on behalf of all, I express my sincere thanks to the panel members. They had patiently given their opinions, perspectives. I think there are a couple of questions there as well. You should give them a chance.
Excuse me, we have a session starting.
Yeah, sorry. Yeah, so
We have one question.
Yeah, one question, yeah. These panel members will evaluate and then decide who is the winner. I asked the question, okay. The question is antimicrobial resistance seen only in developing nations of the world? If yes, why? If no, why? Is antimicrobial resistance seen only in the developing nations of the world? Yes or no, why? This is the question. Anyone answers this question to the satisfaction of these panel members would get a gift hamper from the organizers.
No, sir.
No, you will have to justify your answer. It cannot be yes, no.
No, it's a worldwide problem. It's just that the burden of it is probably higher in lower developing countries. Probably because our population is so high, the sample size of our AMR is higher. Otherwise, it's a global problem.
Anybody else?
No, sir. Actually, it's a worldwide problem because surveillance in Western world, in the developed world, is very good. That's why the data is accurate data what we can do. But in India and low economic countries, the surveillance is not that much good. That because of that data may be fabricated. Also, it's maybe incidents also less showing. So definitely, it's not a problem of low middle countries. It's everywhere. Sir.
Yeah, problem is there in the developing and developed world, but in developed country it is more of gram-positive organism resistance, MRSA, VRE and all, and developing countries more of gram-negative MDR we are seeing. And the reason is in developing country it is more of related to the poor socioeconomic status, poor hygiene, overcrowding related to that compared to the developed countries.
Yeah, so this is the last answer. It's worldwide, ma'am, and it is more prevalent in developing countries because of various factors such as sir has already mentioned awareness about the antimicrobial resistance and taking the medication over the counter and poor socioeconomic conditions also.
There's someone
who would like to answer.
So now you will have.
My vote is for her. I'll decide fast. My vote is for her.
Conflict of interest is not there.
No, yeah, she's not working with me.
Right, I'm in.
It's okay.
Yeah. But there's one point to answer why it cannot be an exclusive problem. It is because of travel. If somebody has drug resistance here, tomorrow it can be transferred to America. Within 24 hours, it can go there. So it is across. We cannot live in a niche. That's what. One Health.
Thank you very much. Thank you.
Bye, to the side.
Now it is decided. We'll be starting the next session in the next room. Diagnostic safety. Thank you. Congrats, you got it.
This is hall 2, right? So they were telling that's hall 3.
Ours is all 3.
Yeah.
This is also 3.
Oh, sorry. This is 3 or 2?
So the areas of strength, what we had identified from the feedback of the staff, that's a teamwork and a supervisor, managerial, clinical leader who supports, who guide them for the patient safety, so that they are much more involved into the daily operations, so that we got the maximum score. And of course, the potential improvement area, what according to the staff we feel is that the staffing pattern, the distribution of staff, we all know, based on the workload and the workplace. So I should accept that as the hospital is a semi-rural thing, we had a challenge of getting a skilled staff at all the departments, not only nursing or not only technician, in terms of physicians, in terms of housekeeping staff, every layers we had deficit. So amongst the respondents, the staff position, the nursing and paramedics are the highest scorer compared to the managerial staff or the physicians cadre. Area of unit or the work area who scored more, that is the medical ICU and the OT, they are the highest scorer. From this area we received the maximum response, I mean to say. And the respondent characteristics are 56% of the respondent had the experience, hospital experience persons between the 1 to 5 years, and 54% have the worked experience in a individual unit from 1 to 5 years in this single same institution. That is, I want to show. So these are the composite measure as the HRQ had already defined there in their tool. So these you can see that these are the scoring rates, and the average is 64% of all the composites measures. Highest is the teamwork, as already I shown you, and second is the supervisor managerial level for the guiding and supporting factor, and 51% is the staffing, and rest these are individual composites score areas. And the overall patient safety grade, that excellent criteria is 73%, very good is 19%, acceptable criteria means that here the training need is more, so we focus on this percentage of population. Next, of course, based on the result, we had action planning. So these are smart goal development. We had a timeline, activities to follow, process re-engineering if required, we will do based on the suggestions of the staff. So I just would quickly run through the last slide. What strategy and implementation measure we are trying to follow and we are planning to implement in this current year, that is to prevent the skill gaps. The skill gap analysis we are planning to do through the managerial level, so that and anticipated staff need can be done, and we are focusing on the acuity based staffing, avoid staffing shortage, succession planning, knowledge analyzer, control recruitment because recruitment incurred cost, and development of effective staffing plans. And of course our forthcoming idea is to involve this year more than 50% of the staff in our survey, and we will do a comparative analysis. So let's see where we will stand. And this is all the effort we made to engage our staff in our patient safety culture and to induct them into the culture of the patient safety. And, thank you, sir.
Congratulations for the good work you've done, and having managed a hospital in a semi-rural kind of an area, I know how tough it is to first of all find trained staff, and secondly to train those staff. That's again a challenge. But on the other side, also that's an experience sharing that I have noticed. It's the staff over there, once the initial resistance initial inertia you cross towards training, they are more eager to learn.
Yeah, more eager. Absolutely. One positive aspect. Yes.
But kudos to you for doing such a great work.
Sir, we will do a comparative study this year also. We will engage and try to get a better result. Thank you so much.
Thank you. Now we have Bensita Lindsay from Ganjali's Hospital, Kengiri, Bengaluru.
So good evening everybody, myself Bensita, I'm a nurse educator from Gleneagles Hospitals, Bangalore. Kengiri. Judith Vasan. Yeah.
Harshita has not joined us.
Okay.
project is Project Suraksha, Excellence in Nursing Practice, Creating a Culture of Patient Safety. So next slide please. So the word Suraksha in Kannada means protection. So it's all about safety. So safety is a priceless one, and everybody's job is to make sure that safety is there. So first is do no harm is the most fundamental principle of any healthcare service, and no one should be harmed in healthcare. And however, there is compelling evidence of a huge burden of avoidable patient harm globally. So the Project Suraksha, the main alignment towards the global WHO safety goal, which says to achieve the maximum possible reduction in avoidable harm due to unsafe healthcare globally, envisioning a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time and everywhere. And as a WHO census says, 4 in 10 patients are harmed in primary and outpatient healthcare, either due to a fall or through a phlebitis. So we saw everything as a point of IPSC goals, International Patient Safety Goals, which talks about 6 components. The first component says about how to identify patient correctly. The second one about the communication. The third about usage of safe medications. The fourth regarding surgical safety. The fifth regarding the healthcare associated infection. And the sixth regarding prevention of falls. So this project we took as an initiative, and the process how we went through is we tried to create awareness among our own staff. The staff, in the sense, not only the nursing staff, we also included our housekeeping, the transport people, whomever was in first line in contact with the patient care. So all of us, we created an awareness regarding fall, regarding safety belts, usage of grab bars. So all these small touch points, we were giving more of awareness, and the training and education played a very important role in this. And we also did a campaign, a patient safety program for more than a month, and that also created an awareness among our patients, relatives, and among our staff also. So then implementation, we created a patient engagement program like in health education. So we made it a point and we did it. And then last one is we not only stopped within hospital, we also extended as a Guinness World Record, clean hands save lives. So if you could browse in Google, there was an initiative which we done in November 22nd for the maximum number of people were made to sanitize their hands. So this comes under the healthcare associated infection prevention. So this was a very tedious project where we could connect 54 schools, 5,000 teachers, more than 80,000 students, and more than 1 lakh parents were connected through this Clean Hand Save Lives Guinness World Record. And recently we got the Guinness World Record certificates to all our participants. So that is one of the added on credits to our organization. So when it comes to the fall, for the adult we use a Moss fall risk assessment, and for the pediatric it was a Humpty Dumpty scale we used, and for pressure injury we used the adult for Braden scale, for pediatric it's Braden pediatric scale, and push score for the healing pressure ulcers we use the scales. And for DVT assessment we use the modified Wells criteria, and in pain for these are all the different scales we use for different age groups. And this is how our quality indicator of pain management goes. So you can see a consistent raise in the graph, and we use the WHO pain ladder scale, and that is how we were able to give pain management. And we also strengthened our assessment and our re-assessment, so that we could make use of non-pharmacological management of pain management also, not like suddenly going to the pharmacology, try with the non-pharmacology. And also we had a visit by our OT nurses. Once the surgery is over, by 24 hours the OT nurse goes to the ward, she visits the particular patients whom they have undergone a surgery. They see through whether the epidural analgesics they are receiving is adequate or not, or do they need any other additional pain management. So that was done 24 hours. So regularly they were doing, apart from the in charge or the staff nurse who is there in that ward particularly. So these are all the additional precautions we did. And for fall, we created a roadmap for fall prevention. So you could see over here, so this is the, so these are all the percentage. compliance towards pain management and assessment. Both assessment and reassessment. And management also is included. So this is the roadmap we have created.
Is a paper form or electronic or
Paper, everything is paper form, sir. But till now we have not gone to the electronic medical records, so it's all paper forms. And this is the roadmap we follow. And we also have a separate initiative nurse for patient safety, and she also focuses on all these quality indicators, and that is her key performing indicator, that she has to train all the staff and talk about fall prevention. And hourly rounds we do, and we also create an induction in regular classes, role plays and simulation, how to prevent falls. So we just do a dark room exercises, like what all can lead to a fall. So all these exercises will help them. And this is regarding the HAI, pressure ulcers. So this is a graph, and this is one of the best initiatives we have done, the position clock, which we used in ICUs to prevent pressure sores. And this is regarding the wound assessment and wound care. So if any patients develops a wound, so we use the alpha matrices, the position clock, a better nutrition for the patients, and also we make sure we prevent skin sores before they could come. So all the early assessment we do it, and this is all the manuals we also have, so that everyone stands in the same line and path. So all this will, and also we have nursing clinical pathways for all of this, so which is one good practices we have. And this is safety precautions, so the fall prevention, safe infusion practices, and all this. And we had this. These are the glimpses of patient safety awareness campaign. We had it. So we had a slogan competition. We had one selfie booth. We had an exhibition where staffs were involved, and the patients were told what all things can lead to fall, how to prevent fall, and role plays, everything was there. And this is like how to identify a vulnerable patient. Who is a vulnerable patient? OPD based, IP based, all this we have taken into count, and we did. And this is to do with the restraints, and this is safe infusion practices. So one more credit is we underwent an infuse accreditation, and we got an infuse certificate. So that is one more thing. And these are the glimpses of the infuse training we gave it for our nurses. And for medication administration, we have prevention regarding stickers. So lookalike, sound-alike drugs, we have stickers, we separated, and also we have some protocols, and we made sure safety is a social order, and it's a culture of the work. So nobody can just take it as safety just like that. And so all this is one of that. And training and education is the main thing, and we make it as a necessity during our induction itself. And this is an annual calendar we follow across the year, so that every 3 months once it keeps repeating, and we strengthen it across. And these are all the branding things. And we had a nursing symposium where our patient safety paper was also presented. And these are all glimpses. And to add on to our credits, we have having AHP award consecutively for 2 years for the nursing excellence. And our hospital got Critical Care Nursing Society accreditation, which is first in Karnataka. So that is all added to the patient safety. Thank you so much. Which ones?
pressure ulcers.
Yeah.
Zero.
Yeah. Kilos is like depend 3 to 4 days. 4 days. Yes, we have. We have some. Hygiene, yeah.
What do you think is the actual clinical percentage of
clinical percentage? We have tried a lot. How? Because no.
I know it's a difficult task.
Yeah, it's a difficult. I will never say it is a 90 plus above. We are still in the process of making everyone do it, because it tends, we just go ahead with that. So it is like you have told the nurses, if the consultant touches the chart or the patient also, you give him. It's just a gentle manner of providing, offering.
So it's nursing driven as in
Yes.
That's the lady over there, you see.
I am the CNO, so I report to her.
That's something that doesn't change across geographies, across hospitals, across chains. Yes. Thank you for that.
Thank you.
Thank you.
Jariwala from Shalby Limited. Can you introduce yourself with your paper, please?
Good evening, everyone. My name is Kushbu Jariwala and I lead Quality Assurance Department at Shalby Limited, and particularly in the Surat unit. Along with me, Dr. Supriyo Sarkar is here, who is cluster head, and he is the co-presenter as well as co-author for this paper.
Action taken for this study, trained all the staff nurses, appreciated the staff handle compliance. Random files were audited by the custodian on daily basis and handled. Daily file checked by the chargeman or team. Checked by the on-road for review automation.
I'm going to present under the category of promoting patient safety culture. So I'll be talking about an initiative we took in order to ensure patient safety, and I'll be talking about in detail in the later slide. So the title is Co-Production, which implementing co-care board to elevate safety and amplify healthcare outcomes. Let me define you what is co-production as well as co-care, which is mentioned in the title. First, co-care indicates co-produced care, and co-production indicates the patients are viewed as an active participants in their healthcare, examines how their interaction with healthcare providers and services can be optimized. We have been discussing about patient engagement in each and every conference as well as in our daily routine. But now this is the need of the hour, that we need to step ahead of the patient engagement, and we need to encourage patient participation. Patient engagement or patient education is just one-way communication. By this study, I want to show you how we have encouraged patient participation in their care delivery and to amplify healthcare safety. The aim and objective of this study, the baseline study highlights the significant issue of patient falls and non-adherence to dietary instruction as well as restrictions in a tertiary care hospital in India. We aim to reduce this incident by 30% in 6 months. So this is the baseline data. In the month of January to May, on an average, the fall incident were reported, that is 2.62, and the average of dietary non-compliances were reported 7.42. No hospital or no healthcare institution desires any kind of fall or incident, right? We do not need to say how dangerous the fall is. Globally, 6,84,000 fall occur every year, and it results into disability adjusted life years. So our desirable fall is 0. And on the other hand, dietary non-compliances influence, and it results into the delay of the surgery, rescheduling of the surgery, which increases the length of stay, cost burden to the hospital as well as other discomforts to the patient. So conceptualization of co-production. The common root causes contributing to this incidents included communication gap between patients and care provider, leading to misunderstanding or missed instructions. Challenges in interpreting instruction accurately, possibly due to language barriers or complexity of the medical information. Casual attitude towards safety instruction from the patient end, where adherence may be compromised due to the perceived inconvenience or lack of awareness. Polypharmacy was one of the reasons. Simultaneous use of multiple medication increasing the risk of adverse drug interaction as well as error in administration. So now, current challenges always demand creative solutions. That is how we will ended up to the concept of co-production and co-producing. So we conducted this study as every quality improvement project, there is always a PDCA cycle. So during the first phase, we introduced this whiteboard, which is called co-care board, where we mention the parameters of patient demographics as well as instruction related to fall prevention as well as dietary compliances. So this is the first board we introduced. After receiving the feedback, we received the feedback that was the language barrier. Patient could not understand what we were writing. Use of medical terminologies, for example, dietitian used to like salt restricted diet, which patient never understood and never complied to. Strategic placement of the co-care board. So initially when we implemented this board, it was kept on the head side of the patient. So patient could not read it. It was beneficial to the care providers to more extent. And no space for patient or family to voice their concerns. This was more or like less engagement from the patient side. Then we improvised and we categorized into two parts, one for patient and one for healthcare providers. And the language was changed into the patient they can understand. Later on, we came up with the pre-printed version of this board after receiving consistent feedback, and we introduced multiple parameters. But our current focus is still fall prevention and dietary adherence. However, we plan to monitor other parameters also later on. So for this, we encourage patients to raise their concern through this board. It enables their participation, and it increases the compliance from their end. We could see a significant improvement after the implementation of this board. So initially I showed you the baseline data was during the January to May. During the phase 1, which was during June to August, our incident of fall as well as dietary non-compliances had reduced. And when we introduced the phase 2 during the month of September, we are seeing significant improvement. If I show you the percentage wise, the impact of this project, the incidents have reduced over the phase 1 as well as phase 2 by a remarkable percentage, as we can read from this slide. Moving on, from the baseline to the phase 2, we observed the reduction in fall incident by 76.89% and average count of dietary non-compliance is reduced to 71.10%. So with the current focus on fall prevention and reducing non-compliance to dietary protocol, we plan to increase related parameters such as medication safety as well as pain management in future. Currently it is being done, but we are not monitoring it. And our current focus lies in patient care wards, where we plan to expand this initiative to other clinical departments as well as at the regional level with our other units. So currently this is implemented in Surat unit, so we have other 14 units and we plan to expand it. So that is all from my end. Thank you so much. 200 bedded hospital and our average occupancy is 82.
You showed a percentage in terms of your fall and your dietary. What was the base figure that we were working on?
So we
Not
were,
in terms of percentage.
correct. So we were calculating as per 1000 inpatient days. Denominator is 1000 inpatient days. It is progressing, but we do study quarterly. I mean, monthly data is monitored, but I'm going to present till now.
Lovely graph going down, other than January to February increase.
Not really. And the purpose of choosing particularly fall is we are orthopedic dominant hospital, so patients are more prone to the falls. So that's why we are very much concerned about it.
Very, very good.
Thank you.
Thank you. We have Major Shalu Verma from Medanta Medcity. Thank you.
Good evening, ladies and gentlemen. This is Major Shalu Verma. I am a retired MS officer from Armed Forces, Indian Armed Forces from last 14 years. And now recently I have joined Medanta, the Medicity, in the quality department as a quality nurse. And my co-presenter is here with me, our HOD of quality manager, Ms. Karthik Khatri. So I'll be presenting as well. May I start, sir? Dr. Mehta and Mr. Somit. Thank you so much, sir. So we are here since morning. We are listening about promoting patient care safety culture through feedback, and feedback does wonders in maintaining the quality care and having the safety culture for the patient. What is the we can say, how can we introduce this on feedback? Feedback is basically is in a culture, that is an organizational environment, is like setup of examples and setup of this is a communication between the patient directly and the organization to the know about the negative comments, about the positive comments, how care he is receiving, what are the lapse points, where the communication gap has been left. So like it is to achieve the individual collective performance by the different stakeholders involvement to achieve the desired results, optimum care and quality care for the patient. So we started this project started this project in October, and September we have a data that we are getting many complaints from the patient, which is we are not able to fill up. Like there are some stakeholders from the doctors, from the nurses, they are doing their work. They are doing counseling, they are doing treatment, but there are some gaps, like patient is not able to explain, ma'am, what time my procedure will be done? Sometimes doctor is busy. Sometimes one patient I have received in the ICU setup, that nurse is giving physiotherapy along with the physiotherapist, and suddenly there is a visiting hours and then attendant coming, and there is a physiotherapy session going on, and they are doing the back rub like tap 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 something, and they are doing the procedure accordingly, but the patient and patient relative understood that they are beating my patient. That sometimes this happens because this is not explained by the physiotherapist, that is not explained by the nurse on duty, that is not explained, but they are seeing the scenario. So we provide that particular scene has been created by the patient and the patient relative. They get panic like why they are doing this. That is not being explained. So feedback team that arrives and explain each and everything. They are the communication gap is being filled by the feedback team. So we started this project to reduce the number of complaints and have the patient level satisfaction at the optimum level. So there are different kind of attributes in the patient safety. Like patient direct involvement is there. Here the care receiver is patient. We are the caregiver, healthcare provider, doctor, nurses, like GDA. So where the gap is feeling like night duty, GDAs are like sometimes they are pressing the call bell, delay call bell, 5-10 minutes they are taking. That is a common issue every hospital must be facing. So that is a patient direct involvement and effective communication. Like we are receiving so many patients internationally, nationally, ECGHS, ECHS, like we are receiving patients internationally, like there is language barrier between the staff who is giving care. Like nurse is from the northeast and patient is from Iran. So we have a facility of interpreter, we call the interpreter, what is the communication gap, how can we just comfort the patient at our optimal level. Like learning from errors. We are continuously we are doing the trainings, like some medication error happens, some fall error happens. So we are taking the data particularly and we are giving the continuous classes, scenario-based classes, continuous training by our clinical instructor, quality persons, and the empathetic approach. Sometimes we go to the patient, it's some type of approach, it's a mixed approach. Like we go patient to directly with some set of questions that how are you feeling. When we go to the patient, they like express anything. There is a clear communication between the patient, family, and the feedback team. Whatever the like doctors are coming on round, they're writing on and they are going. But nobody is explaining what is the procedure, like what time it will happen. Like some nurses coming for the sample at the early morning, 4 o'clock, and patient is in deep sleep. Sometimes it is not explained by the nurse leaders. They are in a hurry and they just pick and just do the. Sometimes multiple prick history happens, and that is causing like मुझे इतना सारा prick लगा दिया and nurses are not skilled. So we are catching that data. We are catching that particularly staff, floor, and the nurse supervisor who needs training, who needs continuous improvement. So we are approaching by the mixed approach. Like we have 3 tools in our hospital setup in Medanta: paper feedback, online feedback, and link generated feedback and live feedback. Here I will paper feedback, like patient is going on discharge, they are writing on their own views. Sometimes some staff may bias, sir mere bare mein acha likh dena. Sometimes they say like that, and they comment like it is like sometimes it get partial. And there's an online feedback. Sometimes patient get discharged and they are calling from phone on OCC. So we receive complaint, it is coming after 24 hours. And there is a live feedback. I would like to emphasize that our hospital is working on the live feedback, but basically Medanta. That's when this study has been going on a project of like live feedback. So on this live feedback tool, it is amplifying on all the issues, whatever type of issues they are facing with the procedures, for the call bell, for the patient counseling,
any GDA delay. So we are filling the each and every one gap by which we can achieve the optimum level of confidence and trust of the patient in our organization. So we do the regular follow-up. Some negative comments are there, like patient is not at all happy that nobody is listening me. They are coming and doing, and where do I go? Some cultural beliefs are there. So we are arranging some religious teachers for them. We are arranging some like diet issues there. So we go to particular stakeholder. We sort out the issue at the particular time as soon as possible. And the recognition and appreciation. Sometimes patients are like coming and they are liking the staff is working very nice. So we highlight that staff work on the star performer of the board of the hospital, and we get appreciation done in our town hall, like the monthly meetings. And others get motivated that this staff has done something wonderful, let me also introduce them. They get motivated, continuous process we are doing that. And regular follow-up, as I already told you, that by the clear communication. And wherever we get all these data of some negative comments like poor nursing care, delay call bell, and here I will describe about, like we had three major issues we took as our complaints: live feedback and discharge feedback. Before starting this data in September, we have delay response 75%. And we worked on it by our feedback team, regular follow-up, regular taking classes and everything. So we have reduced the number from 75 to 36%. And the unskilled staff, like I've given the previous example, multiple brick. Sometimes a patient is not at all able to explain his needs. So feedback team arrives there. They just check out the loopholes where it has been detected, and we go to the different stakeholders. We come like as a team of the hospital and just explain everything to the patient. Like the small issues, like when we go into round, we take actual 10 minutes and immediate response we show to the patient, like water escalations, how many times it is raised by the patient, washroom orientation. Sometimes staff is busy, is not at all able to tell that there is a bell in the washroom. If you are feeling like drowsy, feeling like dizzy, you can press the bell and immediately staff will come. And procedure-related NPO status, this happens in every hospital, like, sir, kab hoga surgery? And sometimes doctors are busy, doctors are not able to counsel. So it may take 6 or 8 hours, and we do the immediate resolution for the patient and achieve the optimum level of care. So we have faced some challenges in this study also. Challenges are like every time we cannot cover 100% of patients. Our hospital is a very big setup, and so many things like trainings, CNEs, continuous education, some soft skills trainings. So we are always busy, but we always try to cover up all the patients on different floors, assigned areas, and we do regular meetings, in our feedback meetings. All the person will come from billing, from GDA, from housekeeping, from nursing, from ADAM. So we take an identified area, identified person on a particular time, and we try to improve. And this is a continuous process of, like, feedback does wonders. Wherever nobody goes, we go and we achieve the patient safety culture through the feedback. This is from my side. Thank you so much and have a lovely day.
Thank you, Dr. So, one thing that I wanted to probably ask you or see is that we can go back to this this chart is I see the comparison between a live and a discharge feedback. I am not seeing a time scale data over here.
Yeah, it is from last 3 months, like October, December.
So I believe a time scale could be a better representation of, because sometimes what happens is we all have heard about the KEPA, corrective action and preventive action. So something that could be a systematic change that you are bringing and how it is impacting on an overall timescale data is something that would probably add more value. That's one submission. I'm no doubt you've done a really wonderful job over here.
Thank you so much, sir.
You've implemented, and some of the presentations over here, I would like to say innovation is not always required. Honestly, you've probably not done anything innovative, just the regular things. You've just implementation is what is majorly required in our setups. In our Indian setups, we need to just look at implementation, even if we don't innovate much, or maybe one of the presentations.
This is a very simple study we were doing. It's like if you listen to the patient, half of problems are really sorted out then and there.
And innovation at a very grassroots level, like a board we saw. So those things are also really good. But implementation is the key in our setups. So commendable job.
Yeah, thank you so much. Just to adding some point, Ms. Karthik at your quality attorney.
What I would like to say about this is, every hospital has a feedback system. Every hospital work on the discharge feedback, then we analyze and then we come up to the result. But for what we analyzed is, it's too late. When patient is gone, he is given you the feedback, which could be resolved at when the patient is inside. So our focus is, when we collect live feedback, our focus is the patient go happy discharge. So by live feedback, we are, jot down many of the problems which patients write on the discharge, and we say, oh my God, it could be resolved within seconds, or it could have been resolved within minutes when the patient is there. And that is why there is a drop in dissatisfaction, and we are nowadays receiving good discharge feedback comparative to the last, because the life.
Exactly what I
Because the focus is, we are very happy when we get a larger number of complaints during live feedbacks, because then that is why we know, yes, the discharge satisfaction will go up. So it is vice. It is invertly proportional. When we get more live feedbacks negative, we know the discharge feedback will be positive.
Huge impact of feedback, sir.
Thank you so much.
Thank you so much.
Like I was saying, so like what you're mentioning, so on a time scale thing, like an impact analysis, and one thing which I was mentioning was also, how do you systemize the corrective or the preventive actions? How do you systemize the change in your overall delivery? How do we get even the live feedback, how do we bring that also down, is something which probably could have
Just for a small example related to this, just maybe helpful for the others also. We are very much getting, like, during our live feedback, the maximum number of complaints about not refilling the water jugs. Very little complaints at night time. So we analyzed those many complaints, and we made a solution that we analyzed the patients, and we made a solution that during the night time we have one more F&B guy who will rotate and check the jugs by themselves and get it refilled before patient asks. And that is being appreciated by patients so much that our feedback for F&B has gone really well in that positive way. So just a small example.
So we work like as a team to achieve the optimum result. Thank you, sir. Thank you. Have a nice day. Thank you.
Thank you so much. The last presenter of the day, we have Dr. Shaheen Anil from Jupiter Hospital, Thane.
Good evening, sir. Good evening, all those who are gathered here. I am Shaheen Anil. I work as Chief Nursing Officer in Jupiter Hospital, Thane, Mumbai. So let me take through how to build a robust workforce for patient safety, strategies, innovations, and collaborations. Now, the logo and the motto of Jupiter Hospital is patient first. So keeping that in mind, we ensure safety and satisfaction along with strong workforce and utilization of evidence-based innovative strategies and technologies. So if you see the picture, the nurse collaborates with all the department in the hospital. So she, being in the front line of providing direct patient care, she becomes vulnerable to numerous stressors while balancing the needs and demands of the modern clients. So there was a need to strengthen and enhance their knowledge, skill, attitude, critical thinking, and making them competent to provide quality care to patients. So the methodology we adopted is the Kaizen process for continuous improvement. That is, change for the better or continuous improvement. It's getting covered here. No, correct. This is fine, yeah. So the Kaizen is a process which we have used. So this gives a glance and illustrate us what are the problems, causes, solutions and initiatives, and the tie in the middle shows the patient safety. The focus is on patient safety, employee safety and satisfaction. So the problems and causes were compromised patient care because of the turnover of the nurses. There was communication breakdown because of language proficiency. Transition difficulties, like I know we all are hearing this COVID batch, because, and they had lack of instability, a lack of confidence, and there was delay in emergency response because there was no critical thinking. Inadequate competency for senior role, hence juniors had to take up the role of the seniors, and the incidences and errors were high because there was non-compliance to set standards. And to talk about solutions and initiatives, what we did first is we strengthened the opening batsmen. That is the novice nurses, nursing and induction and orientation was given. And we also, the existing nurses, we had a continuous professional development for them. Like as you see, we had wound care nurses, critical care nurses for adult and pediatric, IDCCN, hemovigilance nurse, medication nurse, body boosters, palliative care team, ortho clinical nurse specialist, onco nurse, pain management nurse and IV nurse. And what we did is fine-tuning the skills. So we've used the simulation-based learning. I'm also a simulation instructor, so we used this for all the training programs. And we focused not only the novice nurses, the existing nurses, revise and be wise. That is, every quarterly we take back to basics, so it will be a refresher course for them. Wellness program where the nurses physical, social, mental and the financial aspects were also considered, and there was a holistic approach sessions taken. Learning from incidences, we had a moot court where sensitization of incidents is done. Patient engagement, that is teach back, and community involvement where nurses went to the community and provided various sessions for the community. So how we started our journey is we had a roadmap to the initiatives. We had a brainstorming session and we follow bottom to top approach, and we charted out our vision and learning planner based on the feedbacks, and the training need analysis was done. So we follow shared nursing governance model where we have practice council, education council and quality council. And the professional advancements are, to name few, nurse educators were groomed as ortho nurse, clinical nurse specialist and palliative nurse, daycare nurse to oncology nurse, nurse manager was promoted as education coordinator, team leader to nursing supervisor, RN to wound care nurse and healthcare assistant to PFT technician. Now to peek into our journey, we have collaborative courses like IDCCN affiliated with ISCCM, wound care nurse affiliated with Critical Care Nursing Society, palliative care with Global Health Alliance UK, and strengthening the body boosters. We have one-day team leader sessions of various topics, and nurses were empowered. We have a nurse who is an AHA ACLS instructor. We have a wound care clinic and wound care nurses, pain management nurse, hemovigilance nurse and oncology nurse who goes for rounds, and they are empowered to take decisions, and if they have more challenges they call the respective consultant. We have mass training, that is continuing nursing education on SOPs, HIC protocol. There is something known as team-based learning, that is we learn, where the doctors and nurses come in the same platform and sessions are taken, and clinical pharmacist and CNO also take session. This is a glimpse of back to basics. Awareness on legal consequences, that we had a moot court which I explained to you earlier, where there is a judge, a defense and public prosecutor, and this helps to create the awareness on legal consequences based on the incidences and errors which occurred. Health day awareness session taken by consultants. This is a glimpse of simulation and skill-based learning. BLS and tracheostomy tube care, that is we have tracheostomy champions, hence the transfer of patients from ward to ICU has drastically reduced, and in 6 months we have zero shift of patient from ward to ICU, and also advanced trainings were conducted. Extended nursing services, we go to community and take sessions, and palliative nurses, 3 nurses are trained. Multidisciplinary rounds where they go for rounds to meet all the patients. These are the evidence-based practices we have. We had D-lining of Riles tubes, so hence hinge techniques are used. We have absorbable towel for central line, midline catheter to reduce phlebitis, and epidural fixation with fixomal to reduce the D-lining. And as you can see in the picture, we have an epidural bag to put the epidural pump, and elbow restraint, and to prevent DTI, heel off loading. Communication cues chart were given to the patient, to intubated patient, and the other patient used to show us this communication chart. Delirium assessment tool, and we have TT care, like every bedside we keep this ready so that the nurses need not run about, and verbatim was prepared for line care. So if you see the compliances, the courses and workshops, you can see the numbers which is shown there. And nursing department vision, which we had drafted in the beginning of the year, 72% we could achieve, and annual learning planner 70%, and induction and orientation 80%. So to sustain this, what we have is safety culture, where we standardize protocol, roles and responsibilities defined, audits are conducted, and data-driven approach, leadership commitment, shared nursing governance, and open communication. And non-punitive CAPA is done. Learning and development, promoting work-life balance and learning sessions. And we have nursing grand rounds where there is involvement of nurse as well as consultant. And we talk about live patients to the nurses and doctors. And we have feedback mechanism where we have digital feedback, rounds, Google reviews, and open house, that is CNO goes and meet every new nurse on the 7th day, 7th week, and 7th month. And that is what we do in Jupiter Hospital. So this is a glimpse of how we built a workforce in the hospital. Thank you very much.
Basically, ma'am, you're also following what somebody referred in another patient safety conference initially, which was the BED concept, which is back to basics, education and discipline, right?
Yeah.
Would that summarize your entire presentation? Because you mentioned back to basics.
Back to basics is one of the components.
Yeah. And education.
Yeah.
And discipline, right?
Yeah.
So what I could see is that those are the three pillars that you're doing to achieve your goals.
Yeah, it is a continuous process. Yes.
Which is the culture that you're seeing.
Which is the culture we're seeing. Thank you.
Anybody from the audience can ask a couple of questions in the next 1 or 2 minutes. Thank you so much.
Any questions? So thank you all for a wonderful presentation. Would request all the presenters to be here for a photograph and with the moderators. If you can just, and you can collect your certificate post. Yeah. Yeah. You can come in. Yeah. You can stand. This is your certificate.
Well done, guys. Very well.
Thank you everyone. So thank you everyone, and happy to see participation from North, East, West and South. That was the best part, and you guys have really done a wonderful job in each of your hospitals. It's more than a competition, it's all we're working together for patients' safety. So, and we are working, we have learned so many things from each other, and I believe this is what this forum is intended to do. We learn from each other, we take up the best practices, try and implement some of them back at our places, and that is how we work and uplift the patient safety across the country. Thank you.
Thank you so much.
I think so.
we can summarize in what most of these people followed a pattern which was going back to basics on education, on discipline, and some of them working in places where getting staff would be so difficult. But on the positive side, maybe they don't come in with garbage, as we say. so it could be that you're getting better staff than the rest of the country. But yeah, and some of the organizations being the size that they are, I'm saying live is very easy, but the kind of size and scale that some of you manage, I mean, it can be mind-boggling to a lot of us.
For a smaller size of the organization, 85%.
Yeah. Even a 200-bedded hospital is a large hospital. Whether 200-bedded tertiary is a large hospital. At the end of the day, and the larger it goes, the complexity is, So it's like they say it's like an organism after a certain time. It's ticking on its own. So congratulations, everybody, and I'm sure the hard work will pay. Thank you so much.
Thank you. We learned a lot.
Thank you for participating in IPSC. Thank you.
Hello? అయిపోయింది.
She's a rock star. She's Bengaluru. Him and me have had discussion. He's one of the bad professors.
He's got the same books also, no? Math professor.
COVID से पहले COVID शुरू वाला है. Hello. Protocol लो, masks लो. मैं कहा ये मैं ना mask मिलेंगे protocol लेके क्या करेगा? Then he said okay, I need to recycle them. I said okay. I said I'll send you a protocol. University of Baltimore has done from the US. A friend of mine sent it to him. क्या करना है उसके लिए? नहीं होता. I'll get my marks. But the man is very. Chal man. You need to.
Nice meeting you.
Tell me my
Sure, sir. Thank you.
Need to run.
Whatever happens. Sir, is the photo illa?
Video.
Only video. A photographer is there, na?
Photographer.